Presenting with me today here is going to be a panel of Crystal, and Crystal is our ALERRT lady now. She's the boss, she's in charge. And so Crystal is going to be telling us a background about ALERRT. And once that happens, we are going to get some updates, at least on how things have happened so far with ALERRT in terms of the progress, the achievements that we've come with. It's been a very long, close to 5 years now. And so Dr. Anthony Afumajei, representing John Amwasi, our next ALERRT coordinator, would be here to give us that. And then we'll dive straight into our communication session, starting off by our collaborators who are going to teach us some few things about how to set up a virtual biorepository platform. And Dr. Meshu is here represented, and of course will be assisted by Dr. Tony Modi. And then we would have a next presentation by our very reliable and dependable Dr. Sylvie Kwedi. She has been the one who's made us to know our gaps that we needed to fill. You know, she's like the one who steered the whole consortium. Where are we going to? And so she's right here. She's going to help us to then give us some communication tools that every research team will need to be successful. And based on all the gap analysis that she conducted, we had some successes with a few of our studies that we conducted. One of those was to look for the etiologies of fever, and we have capped that study, FISA, and the boss of FISA, Dr. Anani Baja, I saw him, I know he's coming. He will be here soon, so he's going to present that, and then of course we'll have a very interesting discussion for like 10 minutes. I hand the floor to Crystal then.
Thank you, thanks Palmer. Hello, everybody. Thank you so much for coming today. My name is Crystal Cavella-Jones. I've been working on ALERRT for nearly a year now. Still short time and still learning every day. I'm originally from France and I've been in the UK for for 20 years now. So that's background on me. Now let's focus on ALERRT, which is the African Coalition for Epidemic Research, Response and Training. ALERRT is a multidisciplinary consortium that was created back in 2017. The main objective of ALERRT is basically to reduce the public health and socioeconomic impact of disease outbreak in sub-Saharan Africa. And basically, it's just stopping a threat that could lead to a public health emergency. So how do we do that? ALERRT is actually combining the strengths of its European and African partners, and also by building a sustainable clinical and lab research, preparedness and response network. So ALERRT is an EDCTP funded project, which started on the 1st of December 2017. We're just about actually to finish the 5th year of the project, and we'll be starting our no-cost extension in December next week. So we'll finalize the project on the 30th of November 2023. This is the list of our partners. They represent 13 countries with 9 African countries and 4 European partners. Just giving you a few seconds to go over them. It's quite an impressive list. And ALERRT is working amongst 7 different work packages. So we've got, I'll give a little detail of each one of them, but this is the list: clinical research platform, laboratory research platform, ICT and data management, operational readiness, training and capacity building, the impact and coordination and management, which is where I stand from work package 7. Work package 1, the clinical research platform, is led by Professor Sergio Ollier from program PAXI in Côte d'Ivoire and Professor Pontiano Kalibu from UNRO. So the work package 1, the main aim is to establish a clinical research network that can design and rapidly implement ICH compliant, high quality, large scale clinical studies. Dr. Anthony will go further on each work packages in his next presentation. The work package 2 is led by Professor Amadou Sall at IP Dakar and Suleiman Mboub, who's here today from ARSF. The main aim is to establish a laboratory network with the capabilities to provide integrated support to clinical research. And they also focus a lot on biobanks training at the moment. The work package 3 is led by the team in MRC Gambia with Bay Lamin, who just arrived, thank you, and Harry from ITM. The work package 3 main aim is to develop and implement a scalable GCP compliant robust data management. And Baylamin talked about it this morning at the EDCTP Symposium. The work package 4 is led by Dr. John Amwasi from Ghana and KNAS and Fabien Tayeb from Paris. Their team is responsible for establishing a response framework that alleviates administrative, regulatory, and ethical bottlenecks and ensures that ALERRT can act swiftly to initiate research. We've got the training and capacity building. Palmer is responsible for this work package with Professor Trudy Lang. And their main aim is to enhance and maintain the operational research capacity of the ALERRT network, and they develop a lot of training and capacity development program. The next work package is focusing on impact and is led by Professor Mboub and Shelley Lees at the London School of Hygiene and Tropical Medicine. And they're ensuring that the actions of the network are relevant to and supported by local communities, and that the results of the network's effort have a sustainable impact on health through improved clinical practice and public health policy. And finally, the work package 7 of coordination and management is led by Sir Peter Horby in Oxford and Amadou Sall in Institute Paris Dakar, Pasteur Dakar, sorry. To establish, and the main aim is to establish ALERRT as a sustainable sub-Saharan African network that is linked to international networks and that synergize with and contributes to global health security efforts. Work package 7 is also responsible for looking after the budget as well. I'm going to now leave the floor to Dr. Anthony. Are you there? Yes. To go through the progress and achievements of ALERRT.
Okay, so you're listening, you're here with me. Thanks for having me. All right, so now that we are all on the same page, I am here to represent John Amwasi to give the slide. And John always likes to put me in a tight corner all the time. Good, he's not here to hear this. I hope nobody shares the recording with him. This is high-level summary of the achievements of ALERRT over the period. I'll try as much as possible to restrict myself to the take-home message so that, you know, all the audience will be able to appreciate what you've done. Towards the end of my presentation is something on what we've been doing on COVID so far, which I think is relevant current. And so we will spend a bit of more of the time there. Thankfully, one of the jokes we shared before coming here is how you go to next slide, when you've run out of time and you have more content. Crystal have been able to distill most of what we do as ALERRT, what we stand for. And so I'll skip most of these slides. But eventually the idea really is to shuttle between the bedside and the bench during outbreaks and epidemic, and be able to do this in a way that we're able to support countries and institutions to be able to carry out these activities in a very responsive time. Just like Crystal mentioned, there are 19 partners spread out in 13 different countries to support us in this work. Perhaps these are the pictures of the leads and the co-leads. This is all the additional information I'm adding on to what Crystal has presented so far. So let's look at the progress report. For work package 1, we have been able to establish remote monitoring for studies. Thanks to COVID, we were forced to do this for a visa study and build the capacity to be able to do this. Anani is here. Anani and the team from PASI have done an excellent job. Most of you have given them a tough time when they had to reach out to you for most of the monitoring. We've also been able to introduce clinical research in most of the institutions and teams, especially where it is lacking, and whet appetite for this where local capacity is being built. Maneuvering Ethics Committee in LMIC, so for that matter, Sub-Saharan Africa, is a course we should teach in the university. So far, ALERRT has done an excellent job at helping and supporting various countries deal with the regulators and the Ethics Committee as such. I will leave out the challenges for now and move on to the next one. We've been able to successfully implement the visa study in West Africa, in Central Africa, and in East Africa. And this was done by the teams, especially during COVID. Now, the visa study was supposed to help us be able to pick up something like COVID. And the visa study was, for example, in Ghana, halted by the very same thing we're looking for. So for work package 2, we're able to classify most of the laboratories in the network and do a needs assessment. All right, so we did a needs assessment for most of these laboratories, and we also had training for all the participating countries who were interested. We were able to provide online courses in a bunch of areas, including biobanking and virology, which came in very timely for outbreak research. Now, the IPD and nested study team, most of who are here, have been working very hard to the ALERRT CCP cohort study. Currently, that has been implemented in a lot of the ALERRT member countries. E-learning materials available in GCLP via the Work Package 5 for people who may be interested. This was developed by IPD. Now, for Work Package 3, there was training of data managers across different countries. And we also had some internships at the University of Oxford. I'll leave out these recommendations. Now, for Work Package 4, the idea was to be able to put together the concept for ALERRT, how operations will be and what the responsibilities will be. And we're able to put this succinctly together from the get-go to help members understand how to trigger for help, how to step in with help, and what processes do go through. And you see that these red cap electronic forms were designed, one to be triggered by the parties who need the help, and the other to be completed by ALERRT in response to this. Now, regarding our responsiveness under Work Package 4, we have been involved in research regarding a lot of outbreaks. We have the Lassa fever outbreak in Nigeria, the plague in Madagascar, Ebola in DRC, and COVID-19, well, pretty much all over. These are details of what we've done so far. We have been duly represented by some of the publications emanating from some of the trials that we've had, appropriate recognitions in that regard. Some of you are already here. So monkey response among ALERRT countries, we were fairly represented. There have been a lot of activities going on, research going on. John's group, which I'm part of, responded to the Marburg outbreak in Ghana. We are still ongoing with a lot of research to try to understand what happened and to assess, to determine what we don't know about the outbreak. Now, for Work Package 5, we were able to host the ALERRT Hub through the Global Health Network, for which reason we are here today. Now, we're able to provide a program of support for researchers. So there's a bunch of toolkits and training programs will be made available so that regardless of who you are, which level you are, in which country you are, you can easily go onto the TGHN website and be able to access this and train your team with it. So local participation is something that we take very seriously. There have been active participation in preparedness network, prioritization of actions relating to capacity building and research skill training locally, develop meaningful and targeted toolkits, which are mostly available on the TGHN website. Training materials and resources in multiple languages have also been made available. And these are the statistics of the people that have benefited from our online toolkit and trainings that we have. You can access most of them through the TGHN website, the toolkits, the workshops, and the TDR competency framework, which we use for clinical research training. As far as mentoring, twinning, and collaboration is concerned, we've been working extensively with other networks and working with them in organizing these workshop trainings. We work with the Africa CDC, we've worked with Pandora, and a bunch of excellence, networks of excellence. We've applied the same for our research on COVID, and ALERRT institutions to be linked with other networks as part of the TGHN. I'm sure Frank is here and will be able to speak more to this. So we give a breakdown of the other networks that we've been working with. And so I think for this is one of the most important achievements we have. We do understand the competitiveness that does exist in science. There's nothing like that anywhere else. And yet we're able to still work with our competitors to make sure that the people who need the support, the training and the skills, especially the toolkits that have already been developed, are made available to them so that they can expedite response and research during outbreaks. There's a bunch of workshops that we've organized over the period, and these are just a summary of some of them over the period. So for work package 6, we focused on organizing and hosting international consultative workshops with experts in the community engagement and emergencies. We have been able to consult for systematic review of community engagement in health research in disease outbreaks, which are very important and a breeding grounds for conspiracy theories. We have also been able to do surveys in a number of countries, 4 of them represented there. The healthcare worker survey that was conducted in these countries to assess needs, preparedness, emotional well-being, and things that do affect health workers during the outbreak. Somebody from the London School of Tropical Medicine and Hygiene, a master's student, was being supervised under this work package using the Ebovac and Prevac vaccine trials happening in Sierra Leone. We have contributors to the clinical trial collaborative project to enable and promote informative, ethical, and efficient randomized controlled trials as well. So we show here a few of the workshops. Some of you were there. John in his golden years, some of you can find yourself. This is a summary of some of the workshops that we had, joint workshops and training. Now for work package 7, 92% of deliverables have been achieved to date. We've had the annual General Assembly in Addis, in Dakar and Entebbe. I had the privilege of meeting most of you for the first time when we met in Entebbe. Fantastic tilapia. So the executive meetings happens every quarter, unabated. Then there's a quarterly review by the ethics mentors to make sure that all the institutions involved are getting the needed support. Then all technical and financial reports submitted on time to date. Thanks to the Crystal and Emmanuel, who've been doing a great job at this so far. So ALERRT have been able to raise over 10 million euros so far. And I think that this is one of the springboards we are using to apply for, we used to apply for ALERRT part 2, that you gave us this amount, we were able to raise this amount on ourselves, and we're able to do much with what you gave us. So, just give us more so we can do more. And we show pictures from a meeting in Entebbe. You can see the sharp contrast between Dakar and Entebbe. So to the crust of our presentation on what we've been doing so far, I think that most of the other outbreaks preceding now had been really a warm-up for ALERRT, and our best work, extensive impact was seen through the COVID-19 outbreak, especially because there was no help coming and the expertise on grounds had to be mobilized to go into work. The first will be the ALERRT CCP. We got about 2.2 million euro through the Wellcome Trust to be able to implement the study. And this was based on adaptation of the protocol for clinical characterization by SARIC, for which ALERRT is a member of. And we have developed XML files and a bunch of toolkits to allow every country. So most countries who wanted to characterize COVID in their respective, cities and counties did not have to reinvent the wheel. They just had to access the toolkit and the guide on how to use the toolkit and just implement it in their country. And this is how easy we made things for them. And this is how we're able to get a lot of countries to contribute to research on COVID-19. This was a design we put together to communicate effectively how they can utilize the ISARIC protocol, either using the tier 0 or the tier 2. And so this is also where the biobanking training came in handy, because for a disease you do not fully understand, it's very difficult to construct important research questions and implement assays that are bespoke to answer these critical questions. So the only thing you can do is to gather samples first, then as we understand more and provide logistics, begin to run your assays later. The CCP was run in 6 different countries so far. You see the varying numbers of recruitment so far here. In addition to this, we've been working with the WHO to contribute data to the WHO clinical data platform at the time we were implementing the CCP. 2 countries participated from the ALERRT consortium. We have also been involved in the clinical data platform for this year as well. It's still ongoing, and my colleague Joe Bonnie is leading this in Ghana. Now, we do know about the long COVID, and we've been trying to develop a protocol that will help us to be able to study long COVID, what it is, how to define it, who has what, are there variations in this. And we are contributing to the protocol development, CRF and other toolkits that are required to implement a study of this nature. So for the nested study, which most of you here may be involved in, what we are trying to do is to juxtapose a steroid study and a detailed laboratory component to the existing clinical characterization, where we begin to go to several tiers. Samples are collected, immune response is assessed, transmission dynamics, epigenetics, and a bunch of other things to help us really understand the disease. Now, to the healthcare worker survey, which was done by 4 of the ALERRT countries. This has been so far one of the most promising studies that provided information on the impact of COVID-19 on healthcare workers. And so far, we had a little over 9,000 respondents to this survey. You see here a summary of some of the aggregated data from the respondents who were involved. There was also a stakeholder mapping and engagement for this as well. Now, we had to collaborate with ISARIC and MORU for an ICU registry in Ghana and a bunch of other countries. Now, what has been done so far is to collect over 8,000 patient data in the ICU registry with a dynamic dashboard. And the implementation of this ICU registry, especially during COVID, has been one of the key things we have been able to set up. And it's important because now it is serving as a blueprint to be able to implement this in a lot of African countries and create a network of ICU registries where we're able to get these data in real time and be able to use this to inform study designs and strategize on, how to manage outbreaks. So currently we have applied for ADCTP3 with the main theme as an adaptive platform trial application. And we have over the period closely collaborated with WHO, Africa CDC, the Africa Academy of Arts and Sciences on COVID-19 in various ways, in various forms. Most of you have been invited as speakers to speak to the disease at various forms and times. We were able to have more than 2,500 researchers and health workers involved in a COVID-19 workshop that covered 30 countries and 145 African institutions. So far, we awarded 1,500 certificates during this period. So we were able to establish clinical trial competencies through COVID. There are a number of trials. One of them was the Sanofi Pasteur vaccine trial on COVID. The other was anti-cough, with 2 additional ancillary studies that were observational. And there was also the recovery trial. Both anti-cough and recovery were adaptive platform designs, and this is also the springboard on which we want to apply for EDCTP3. We have successfully implemented this at a time there were no there were limited resources, and so we want more funding to be able to set up adaptive platform trials, especially in SSA, so that we can be ready to move with interventions during outbreaks. Did I just mess up? No, not really. And over the period, we have recorded 350 publications from all partner institutions across the ALERRT network. Thank you. I hope I do show well, the contrasts do show well in the background. We've had several public engagement. Most of you have been able to engage the media to break down what COVID is, to be able to demystify conspiracy theories that were brewing in a lot of LMICs. And for the first time in most of these countries, we had authorities and experts speaking to this and, you know, demystifying conspiracy theories. I know what it means when Crystal just moves across the room. Yeah, I got that. I got that. I'm landing now. Thank you for, but you're far too kind. So there have been a lot of literature, there have been a lot of news items that captures most of what we do. Of course, there have been challenges, ethical clearance issues. There have been implementation and training limitations. In some of these countries, politics, geopolitics did not allow researchers to do their job because governments were not sure what they will find and were not willing to open up about some of the findings. Remote monitoring was also an issue because of limited access. Resource mobilization. ALERRT is telling EDCTP that despite the 10 million, we still need a lot of money for the things we want to do. And so we are challenged with all the money we have. And this is really true looking at the impact. You have to look at the work that is being done to be able to determine how much funding we need to sustain this. There are tools and technology that are limited in most of the sites. Quick and relevant output has been an issue, and we are always racing against time, doing very much with very little. So some of the key achievements have been that 81% of the tasks have been completed so far. Over 8,000 people have been recruited in the FISA study. From CCP work that have been done, healthcare worker survey that have been done, community engagement, training and response to these outbreaks over this period of time. We have a no-cost extension, and we are focusing most of our activity on database to track bacterial AMR, biobanking training, and also sustainability plan for ALERRT. So these are concluding words for you all. And the question is how to sustain this. And we hope that this will be the focus of our discussion by the panel and the interaction sessions. I will end here. Thank you for your audience. Thank you very much. This is why you clap for me, and you know.
And please join me to welcome Professor Neil.
Yes. Thank you.
And I'm sure that that's going to be a joint presentation with another.
Yes. Yes, I'm sharing my platform with the other Tony here, and so I'll quickly introduce Dr. Anthony. Yes, Tony Moody, and he is the director of the biorepository and sample accession unit and repository at the Duke Human Vaccine Institute, and he will follow me. He's the storyteller. I'm not. So today what we are challenged with and faced with is to communicate to you and a topic that we've been talking about this morning. And I see a few familiar faces who are in our morning workshop about what are the communication hurdles to navigate within a team that you created virtual biorepository. What we mean by virtual biorepository really is about how you keep your samples and still be a part of the network. And as you're talking about work package 2 with Amadou Sall, it's a group that I've worked with quite closely. And so it is something that we need to come together because many efforts are put this way. So how to communicate this message to you. So the NIH has established a Center for That's a Mistake Research and Emerging Infectious Diseases, CREED, to foster global health preparedness through research collaborations with partners around the world, especially where infectious diseases of high threat can affect many. And for myself, from the Colorado School of Public Health at the University of Colorado, we've embarked on building Coalition the Willing to foster and promote research and capacity building through access to qualified biological specimens and metadata so that we can have a broader collaborative research and in hopes to evaluate diagnostics and determine vaccine efficacy. And so CREED and CSPH have jointly come together to see the mutual benefit of doing this together as opposed to doing it separately and leverage what we have. And we hope we can share with you today some of the things we want to do that you can leverage yours with us, because I think the real challenge is to communicate the need for biorepositories and to ensure sustainability. So it's a slightly a topic that you may not have heard that much about except through work package 2. But what we want to do is share the information and communicate the need today. So today we're going to give you a talk on biorepositories, on examples of what laboratory needs, but it's overwhelmingly unfunded. And why a virtual biorepository and what does it do for you? The idea being that you are the custodian of the samples that you have collected and you keep it where you are, and that the making available to share upon agreement is usually its best thing. It's not to put it and give it to somebody else, but you actually maintain the custody and oversee its use and ensure its quality. And then, what you want to do to navigate and champion for this. And I hope Tony can give you a little bit of that. So I'm going to give this to Tony, and here we go.
Thanks, Meg. So I guess I'm tasked with being a storyteller. I'm not going to match you. There's no way. That was impressive, I must say. And for those of you that heard this morning, feel free to go to sleep. I'll wake you up at the end. You don't have to hear it again. So what I'm going to talk about is just how I think about setting up a biorepository. As May said, I'm co-director of the Coordinating Center for the CREED Network. We are thinking very much about how to set up this kind of virtual biorepository network, because the samples don't need to go to a central location. We need to make sure that people have control of the samples where they are. But that does mean that there are a lot of questions that you have to ask. And in some sense, asking these questions is a little bit like going to somebody's house and saying, yeah, can I stay in the room? And when was the last time you washed those sheets? And how did you wash those dishes? And, you're kind of digging into people's lives here about how they run their biorepository. So what I'm going to talk about is the communication issues and really sort of focus on the fact that you do have to ask a lot of rather difficult questions here. So I'm going to jump through a bunch of these here. This is part of a larger talk. So the reality is, if you're going to set up a biorepository, whether it is virtual or physical, it takes a lot of resources. These things are expensive. There is no way to set up a biorepository without a lot of money. And that means investment, either from funders or from your institution, from your government. You do have to think about how you're going to fund all of this. And the reality is most institutions don't want to do this because it is expensive. That in addition, actually housing all of this material takes space. And the reality is, when you're in an institution, space is money. No matter, even if your institution doesn't think money is the most important thing, Any space being used for a biorepository is not being used for something else. And if you just have a bunch of freezers sitting around and nothing is going in and out, the institution's going to go, why should I keep doing this? What is the purpose of this? So the reality is you have to think as a biorepository director about how are you going to have sustainability there? And the truth is sometimes you can pay for things on certain funding streams and sometimes you can't. As an example, I have to take samples in for an influenza biorepository. I have agreed to take on 400,000 specimens. I was told I can buy no freezers. I can buy no equipment. So I have to go to my institution to say, come on, help me out here. And, that's a negotiation. So if you're going to build a virtual biorepository, a big part of what you're going to be doing is guiding people on how to have those negotiations with their institution. And that means they need to know who to talk to. And importantly, if they need to get support from their institution, do they get it from a single person? Are they getting it from the university as a whole? Are they getting it from the government as a whole? Is it a single minister who's promised it to you, or a single president or a dean or a division head or whatever? And when that person moves on, gets promoted or whatever, do you suddenly have to renegotiate everything? You need to think about these things ahead of time. And so if you're building a virtual biorepository, you need to guide people through that. There are lots of considerations for this, right? The physical footprint that it's going to be in, the infrastructure that's going to be there. Do you have backup power, right? Load shedding here in Cape Town, freezers going up and down on power is really, really hard on them. So, you do need to think about that. Do you have access, physical access, and is there security so that the samples, somebody doesn't just come in and walk off with things? Not even maliciously, just, people do things that I had a freezer one time that somebody walked in, took my samples out so they could put their samples in and left my samples on the counter. Next day, my freezer had a lock on it because I couldn't put up with it. So you just need to think about those kinds of issues. What's your record keeping going to be? Ideally for a virtual biorepository, it needs to be electronic. But that means you have to invest in a system, and that is a cost. You require IT people, data people. And then what are your metrics of quality? Like, how do you decide that the samples are actually valuable? And that's not so much being mean. It's just saying, like, how do we define that and have a conversation about it? There are also other considerations, like how do you implement a labeling system? How do you actually get people to buy into the same kind of system? Who holds the metadata? The sort of dirty secret of biorepositories is the inventory data and the metadata often don't live in the same place. How do you make those connections, and what data can be shared so that you can actually have value there? What's your staffing situation? Do you have dedicated staff, or are you borrowing staff from something else? And that is an important thing. What's your training protocol? How are people being trained and proficiency tested and evaluated to make sure that they're actually doing the protocol that you think that they're doing? And do you have external oversight for that? Do you have auditors come in? Are you the auditor? And, what kind of warning do you give them that you're coming in to audit them? Do you have a chain of custody procedure, right? Do you know that the sample that was drawn, that was then transported, that was then processed, that then went into the freezer and then went to the laboratory? Can you track that? That is a huge issue for making sure that the samples are what you think they are. And then do you have reconciliation procedures? Do you have procedures for discarding and destroying samples? And do you have a procedure for dealing with deviations? Because all of these things come up in any clinical trial. So let's see here. 1, 2, 3, 4, 5. There we go. Okay. So I practiced. So there are a lot of ways to think about biorepository models. And right now we're talking about a virtual biorepository. The truth is samples have value when they're used, right? Samples are not wine. They don't accumulate value over time. They're not paintings that, holding on to the samples, if they're not going to be used, they're just taking up space. But the reality is everybody who collected those samples worked really, really hard to get them, and they don't want to see them wasted. And of course, we all want to have our work recognized. I mean, I think Anthony just gave an excellent talk on recognizing that everybody who contributes needs to get credit for what they're doing. We all need to get promoted. We all need to get published. How do you ensure that all of those things are being done? And nobody wants to be the researcher who gives away the samples that are suddenly in a Science, Nature, or Cell paper, or somebody wins a Nobel Prize and you're forgotten because you're the one that got the sample. And also, you don't want to be the person who gives away the thing that suddenly makes somebody rich, right? We would all feel like a jackass if that was the case. And, we really do want to believe that our colleagues won't take advantage of us. We all believe in this kind of model that we're all together and we're just, we're doing science and it's fantastic. But the reality is most people who collect specimens, they're like this. They are sitting on top of their treasure hoard and they're going, mine, and they don't want to let it go. And the truth is, we really do need to figure out, like, how are we going to share things but respect people's work, what they put into this. This is the incredibly important thing. Okay, so I'm going to skip over all of the model stuff. We can talk about that at some other point. This is the important part. This is in terms of communication, these are the biggest issues. It really comes into, do you have permission to do what you want to do with the specimens, right? And how valuable are specimens if the identifying information has been stripped away? Right? So how much information do you need to have to say that a specimen is valuable? And you need to think about that up front. You want to make sure that you're transmitting enough information so that whoever's using it can get the answer that they need, but you can't give everything. You're not going to give, well, this was the GPS coordinates of the person, when I drew the blood, and here's their address and here's their tax information. You're not giving all of that information, but things like sex, things like age, those kinds of things are probably important to go with the samples, but it may depend on the study. And so you need to think about that as you're setting up your virtual biorepository. Who benefits? That's a big thing here. And there are obviously a lot of regulations in place to try to make sure that there is less parachute science, but that needs to be a conversation up front. We need to make sure that people's intellectual property is respected, and that varies country to country. We need to make sure that people's ability to get promoted, get tenure, get whatever it is they need from their institution is respected. And how do we ensure that that's going to be in place? And it's much easier to negotiate that up front than it is to try to do it on the back end. I've seen nasty fights on the back end. Talk about it up front. Probably the most important thing. And then, of course, the last Latin quote there, who watches the watchers, right? Who is involved in the governance structure to make sure that the samples are actually being used in a way that is appropriate? And so as a biorepository director, the thing I remind myself every day is possession does not equal permission. Just because I hold the sample doesn't mean I can do anything I want to with it. I am a custodian. I am there to hold on to the sample, and the person has given me permission to use that sample for very specific purposes. I can't just give it away because I happen to have it. So the concept is really the legal concept of a trust, right? We think about trusts in terms of money, but really a trust is about who is protecting the rights of the person who gave whatever it is that you're working on. So there's a grantor, the person who gives to the trust. There's a protector who watches over the trust. And then there's the beneficiary who receives things from the trust. And when you're talking about a human clinical trial, the participant is the grantor. They're the ones who have given you their information, their biospecimen, whatever it is. The IRB, the ethics board, is the protector. And it is important to make sure that that is respected whenever you're dealing with specimens. And then the researcher can derive benefit. Oftentimes, the biggest hurdle I face with researchers is they don't want to tell me what research they're going to do. And I'm like, no, you have to tell me what it is you're going to do, because it may change the answer about whether or not you can actually do it. Oh, you want to go and diagnose a disease that actually has clinical importance to this person that we never asked permission for. I'm sorry, you can't do that. That's just not ethical. And so researchers get a little prickly when you start bringing that up, but you have to ask those questions up front. Sometimes there are multiple layers for this, right? I'm a biorepository director, so I have protocols that allow me to bring things into the biorepository, but I still need to go through this process before I release things from the biorepository. So we were talking about this at the earlier session. The way that we do it is we have ethics review every time we release specimens. We go back and make sure that we have permission. Yes, it delays things, but it also makes sure that I never have to go back and have a very uncomfortable conversation with the ethics board or anyone else to say, yeah, I screwed up. I mean, I'm a human being. I screw up. I don't want to screw this up. This is too important to mess up. The truth is this applies across the board. So animal studies, and we're not really talking about animal work here, but a lot of what we do in CREED is animal work, but there's a different set of regulations that you have to deal with. The same rules apply. You still need to make sure that you are following the ethics rules and the regulations of the country that you're in and international law as it applies. And the reality is every time you're dealing with any kind of biorepository specimen, you have your institution, you may have your local government, your province or state, your national government, and international law. You have to think about all of those. They're all applicable. Now, oftentimes they just defer to somebody else, but it's on you to know and to think about it and have a process in place and have people who can actually navigate this. That's the hardest thing. Most of the time when people set up biorepositories, they don't think about all the support staff that are necessary. So the last thing I want to talk about here is other considerations, right? Biosecurity is a really important consideration. We were talking about select agents and pathogens of concern in our previous session, and I'm almost done. This is my last slide. So if you're going to set up a virtual biorepository, who has the rights to see it, right? Do you want to have a situation where you say, yes, at this specific city, at this specific address, there are vials of virus, that could be a potential pandemic threat. I mean, we've all seen that movie. It doesn't end well. So, do you really want to have that level of view, or do you want to have some sort of rights that people have to go through in order, or permissions they have to go through to be able to see it? How do we support the infrastructure, right? Just because people can do it today doesn't mean they can do it tomorrow. And we need to think about how we're supporting all of that. And then, of course, there's politics. And unfortunately, we navigate politics at the local level, the national level, the international level, and it continues to change because the person you knew before may no longer be there. Just because you solved this problem last year doesn't mean you've got it solved this year. So it requires ongoing work to continue to maintain relationships, especially when new people come into positions of authority. You may need to renegotiate your role with them so that they can understand where you're coming from. So that's the end of what I was going to talk about, and I'm happy to turn it over to the session and we can discuss it.
Okay. So Dr. Query is going to present us then the communication tools that every research team needs to be successful. And yes, trust me, she's been a very, very good resource for ALERRT. Thank you.
Can everybody hear me? Okay, thank you. Great. Okay, so I'll tell a short story about communication. As part of the ALERRT projects, we conducted the clinical characterization protocol that I believe was brought up earlier. Clinical characterization protocol for COVID-19. We all know that communication with COVID-19 went all over the place. So imagine now you're in Cameroon and you're conducting a study. One thing that was, I would say, pretty traumatizing for the research team was recruiting patients. We basically had to go into a hospital setting and test anybody that came into the clinic for whatever reason, whatever brought them into the clinic. We tested them for COVID. And we were particularly in non-governmental clinics because most of the response in Cameroon was concentrated in the public facilities. So in our study, we went to the non-governmental facilities. Anybody who came got tested. First, they got the TDR, the rapid test. And if it was positive, they were positive. And then we requested their consent to enter the study. If it was negative, we collected samples for PCR. So one of the patients that was tested positive on the rapid test. And he went off. It was basically a disaster. He's like, what do you mean I have COVID? No, I did not come here with COVID. You tested me for COVID, so you gave me COVID. He didn't come for COVID. He wasn't feeling well. We, as a research study, tested him and he turned out to be positive. Major communication crisis that we had to manage. Looking back, whew, we made it, but back then it was a big deal. So just to say that at every single point during your research, communication is important. So we are researchers. We don't do research for nothing. Research, we collect, actually we gather knowledge and we try to make it make sense. We want to be effective. The knowledge that we end up having, we don't want to just take it, put it in a drawer. No, we actually it has to be meaningful. It has to be applied in order to help health, because we are health researchers, in order to help with health in our communities. So whatever it is that we do, we want to be effective. And we want to know our audience. We want to know the interests, we want to know the needs, we want to exactly determine what it is that they need to know. Basically, if you don't get anything from my talk today, just remember this. You need to know who needs to know, what they need to know, when they need to know. Because not everybody needs to have the same information at all times. So if you don't remember anything else, just remember that. So not only do they need to know, so you have to communicate, and you have to be clear and concise in the messages that you're communicating. And when you communicate, you have to be able to have trust to the people you're communicating to. If there's no trust, they won't believe you. And before you know it, you're giving them COVID. That happened because there was no trust between the patients and the healthcare personnel. So you do need to build trust. And in communicating, you need tools. The tools that you need for building the trust that I just talked about, creating an enabling environment for you to work, to identify and respond to incorrect information. Especially with social media these days, it can be all over the place. And the tools that you need will also encourage the uptake and eventual application of your findings. Like I said, we don't want to do research to put the data in our drawer. It has to be applied. It has to be helpful to our societies. Oh, shoot, I keep forgetting. Okay, I'm sorry about this, these slides. The communication cannot be an afterthought. It cannot be something that, you know, you have written your protocol, you have gotten your ethics approval, you have gotten your budget, your finances, you're ready to go. You're actually going, oh, well, hold on, I have to communicate. No, you have to plan it in advance, and you have to budget for communication. It has to be in your budget lines. You have to have a budget lines, particularly for communications. And many of us have research projects, multi-sites, multi-country, where communication ends up being extremely crucial. You have to budget for people that are whose job is specifically for communication. You have to budget for the tools to communicate. You have to budget for the training for that communication, the materials, dissemination of results. One thing that I have been experiencing lately is that sometimes, you know, we count on these waivers that the scientific journals give us as researchers from low and middle income countries. Sometimes because you don't have that budget line for publication, you end up not having as many opportunities to publish as the people who actually have that money to publish. So basically, you have to plan and you have to ensure that you have the money for it. Okay. You do have to develop a strategic communication plan. Basically, just because you have a plan at the beginning doesn't mean that it will not change. We have these research projects that last for 5 years sometimes. So you may have had a plan on day 0. It's not the same plan year 3. It's not the same plan year 5. It's an evolving document, living and breathing. It expands, then it gets reduced, then it's really living and breathing, and it changes as your trial or your study or your project is evolving. Speaking of communication, I only have, well, Palmer said 15 plus 5. Let's say 20 minutes for this, but there's actually a whole classes written on communication. So I'm speaking in general, but do remember that not only do you communicate with external stakeholders, you also have your internal team within which you communicate. So whatever plan you develop, it has to be for external stakeholders and your team members as well. I'm gonna learn, don't worry. So your stakeholders, I said stakeholder, who are your stakeholders? A stakeholder is any person whose view or decision will affect your ability to run your project successfully and to promote its application. We don't just do the project, we actually apply. That's a stakeholder. So you really have to identify them all. Typically, the study participant, the staff I just mentioned, study management, the sponsors, regulatory authorities, government officials, community advisory boards, community-based groups in the community that you're working within, your colleagues, your partners, your international advocacy groups, other the press, local, national, international press, donors. The list can go on and on and on. Basically, your stakeholders is anybody whose view or decision can affect your ability to not only implement your study, but also apply it. And communication, like I said, it's a reiterative process at various steps as you're conducting your research. It's not just at the beginning, it's not just at the end. Here, I don't know how clear this slide is for you, but I actually got it from a handbook that was published by FHI. And I thought if the way it presents the communication task parallel to the milestone was quite good. So for example, as you're identifying your site and developing your project, you start planning for communication. As you're training, there are some specific people that you need to address. As you're launching, there are specific tasks that you need to, specific communication tasks that you need to address. The worst thing that you could do as a researcher is to start a study into a community and they've never even heard of you. They've never even heard of your study. That is the very, very worst. And many of us here in this room work in areas where communication is not the same as what we learned in the classroom. I can tell you that. I work in extremely rural areas, and the way I'm speaking to you right now is not the same way that I'll be speaking to them. So I cannot just go into a community and start asking for consent. Doesn't make any sense. Throughout the process, your stakeholders have to be engaged all the way to the end. We've heard about ethics since this morning. It's completely unethical to conduct your study, get your data, publish. And I heard about, oh shoot, there's a term that was used this morning that I liked a lot, something about metrics. Educative metrics or performance metrics, because we all want to be promoted, we all want to publish, we all want to increase our visibility as researchers. But that is fine and good. But sometimes we forget to take back our results to the community. The community where we did our research is not going to read Lancet. It's not going to read Nature. It's not going to read, there's so many. Thank you. There's so many. We have to go back and actually disseminate the result in a way that can be understood by that community. So it's not about publishing only. It's not about networking with the higher ups in government and changing policy only. It's about that, but it's also about the community where we conducted our studies. Okay, here we go. And communication is not only to be done during a crisis. It's not when everything goes awry that all of a sudden you're supposed to communicate, but it does happen. And during a crisis communication is even more particular. It's more particular. It requires particular training. Not anybody can just stand up and start talking on the radio or talking on television when there's a crisis. It takes particular training and particular steps. Because you don't want to wait for a crisis to happen as you're planning your study, and many of us actually, when we're writing grants, they ask us for a risk management. So as you're planning your study, you have to think of what could go wrong. You had to think ahead. You had to be proactive. You really had to think of what exactly could go wrong. And if this happens, what will I do? So during crisis, trust, transparency, truthfulness are essential. If you don't know the answer, it's okay to say you don't know it, as opposed to BSing through it. It's okay to say, I don't have this information right now, but let me go get it and come back to you. That's transparency. That's that builds trust, and truthfulness is important when you're communicating during the crisis. I was talking about disseminating results. We disseminate at various levels. I do appreciate fora such as these ones that actually allow us to communicate our results in an international within an international platform, but we also have our national platforms and we have our local platforms that cannot be discounted. Also, in these days, writing grants, they ask you for a dissemination plan. It's quite important to plan it out all the way to the community. In Cameroon, actually, where I'm from and where I work, there's the Ministry of Health has a direction of I think they call it directional operational research, and they actually require you to disseminate, and they require that they take the lead in that dissemination, which helps a lot because they have all the right access and channels for proper communication. So, okay. We are Dr. So-and-so, Professor so-and-so, and some of us have 10 PhDs and 20 masters, and we know science. We know how to, we know exactly what we're doing. That's good and well. But when you're communicating, you have to be very clear, concise, and speak in a manner that can be understood by your audience. So when you communicate science, you have to be clear. I really like this saying. I saw it this morning. I said, I had to add it here. And okay, so Albert Einstein is in the background. You can see him in the background, very smart guy. And he says, if you can't explain it simply, you don't understand it well enough yourself. So even with our 20 PhDs, if I could not explain to the patient that I did not give him COVID, I only tested him, that means that I myself did not understand what I was doing. So it humbles us. Oh, I'm sorry. I have to go quick now. I think I'm back to I used up the 5 minutes. So in terms of research findings, this is kind of a canvas of the different aspects of communicating our research findings. We have to know our audience. We have to know exactly why we did the research, the essence of the research, what is the motivation behind it, the benefits, the channels, who needs to be engaged when we're communicating, the tone of voice with that we use. We have to keep it in mind because it's very easy for us to come on our high horses. Don't forget, we have 20 PhDs and start talking as if the people that we're communicating to don't know what don't know what we're talking about. The tone of voice needs to be proper. The content, the vision is exactly where you're going with your research. The mission is how you get to, or how you will get to your vision. So these days, lucky us, we live in an era where we have so many tools. 20, 30 years ago, many of these were not available. There are quite a few tools online that will help us with our communication. I won't go into every single one of them. So in conclusion, communication is important. Knowing our audience is important. Knowing exactly what we did, why we did it, how we talk about it, who we talk to, is important for us to be able to share our knowledge. Let's remember that we're doing research to gather knowledge, to produce knowledge, and we have to do something with that knowledge. And it has to be applied. So even though there can be many guidelines and constitutions, but without tools, without proper and effective tools, we'll be talking, from here to China, we won't be effective. We need the proper tools. And communication is not just external to our teams, but it's also internal to, and it's not just external to the external stakeholders, but also internal to our teams. And don't forget build trust, be transparent and truthful. Thank you.
I guess I have to say thank you very much. And we will go straight to the next presentation. And I think Pierre is going to get all the experiences that we had as a consortium from our major study through the main guy of the time, Dr. Ananiba. Please join me to welcome them. To present the experiences that we got with Twitter and with our nested study that are still going on.
Yes, thank you very much, Palmer. It's a little difficult to speak after these great presenters and fluent presenters. I'm Ananiba J. I'm from Côte d'Ivoire. You have to take that into consideration because it's a French-speaking country. Okay, so yes, the organizer asked me to talk about my experience in FISA as part of ALERRT. Okay, so before going any further, let's look at this slide with this simple definition. What is a project? An individual or collaborative enterprise that is carefully planned to achieve a particular aim. Collaboration is a situation of two or more people working together to create and or achieve the same thing. I underlined and bolded some word or group of words to emphasize. In research project, the particular aim is to answer to a research question. Can you hear me very well? Okay. Okay. So research project is the situation of two or more people working together to answer to a research question. So can we work together in a collaborative way without communication? I think the answer of this question explain the importance of this symposium. So why communication is so important? Communication is crucial to ensure that the progress is smooth and on time. As you may know, the project management is based on 3 pillars: time, scope, and cost. So you have to strengthen these pillars, and I think with communication, you can do it. To create and maintain motivation within the teams, this is very, very important, because you can start, and most of the time, people are very motivated at the start of the project, but as the project evolves, you can see that the motivation gets weaker. To ensure that the team members are aligned with the project objective and understand exactly what is expected of them. This is also important. Currently, we have the Soccer World Cup, and if in a team, players don't know what they have to do, you can imagine if the goalkeeper doesn't know that you have to catch the ball. I let you guess the end of the match, okay? To build trust, and I think Sylvie talked about this, to build trust so everyone works together from project start to finish. And at the end, communication is crucial to the success of a project, to achieve the achievement of objectives and to answer to the research question. So with communication, we can make team to become together, everyone achieve more. Let's look at this slide, what lack of communication can make, and you see they will not achieve their goal. They will even hurt themselves. And the time of communication come, the sooner the better, but they decide to communicate. And now this is the effect of communication. They will achieve their goal, and they will together make things good. But I think we don't have to follow this example. We can start by the communication and experiment the effects of communication. Okay, ALERRT, I think Christelle talked about ALERRT, 19 partners, 13 countries, 4 European countries, 9 African countries. And as part of ALERRT, we implemented a FISA study with these objectives. The scientific objectives was to describe the epidemiology, clinical aspect, and management of febrile illnesses in sub-Saharan Africa. And the strategic one was to build a clinical research network capable of responding rapidly to epidemics. Okay, this is the organization of the FISA study, and I think she talks a lot about this. All work packages were involved, managed by the work package 1 in charge of research. All the work package, so you can imagine people we have to manage in this study. So communication was very, very important. We implemented FISA study in 3 regions, West, Central, and East Africa, 11 countries, and 15 sites. 8 sites in West Africa, 4 in Central Africa, and 3 in East Africa. The FISA study was organized, the management was organized like that. We had at the top the International Coordinating and Monitoring Center, and we have 3 regional coordinating and monitoring center in each country, in each region. And under the regional monitoring center, we had the site, the clinical site with a supervisor. The supervisor was the institution that proposed the site for the study, and a PI was someone in the local team. So you can see through this diagram how we organize communication, how we organize the management, but it was also a support of communication. The setting up of the FISA study, as Sylvie said, the communication have to be planned, okay? It should not be something that we do like this, okay? So we develop several documents, SOPs and tools, and these tools help organize the communication. First, the ALERRT Gantt diagram. Okay, this was designed by the ALERRT and was in the ALERRT consortium, but it's tools, communication tools, because thanks to this we know what were our deliverable, the milestone. This is for work package 1. So this can help us know what we have to do and where we have to go. Okay, so all the work packages have is deliverable and milestone. The division of responsibilities, we drafted this document as part of the work package 1. And in this document, we have all the responsibilities for each work packages. And you can see that all the work packages work together, and we see the interaction between all the work packages. So this is also a communication tool, very important, because as I said at the beginning, communication ensures that all the participants should know what they have to do, because if you don't know what you have to do, it can be a problem. The protocol, you will say that, yes, we cannot implement a study without protocol. And I say, yes, I agree. But this is a very, very good communication tool, because in the protocol, we have all the objective of the study, and it helps us doing things together at the same time and in the same way. You see, we implemented the study in 15 sites. Can you imagine? So we need to have a document that help people doing things in the same way. So we even drafted a procedure for the protocol development, and the SOP also, the same applies to the procedures. Okay, so the procedures are also communication tools. Okay, we drafted procedures including the budget. You can see on this slide, I talked about building trust, and this is very important. I don't know in English, but in French we said money is the nerve of the war. I don't know if they said, okay. So this can drive problems if things are not very clear. But we drafted this, and all stakeholders were aware of what was the budget for each site for the regional coordinating center. So we try to be transparent. Site selection also. because we selected site, we drafted this procedure, and each partner that wish can propose a site, at least one site. They propose one site and we make the selection. It was a process endorsed by the General Assembly at the end. So things were very, very clear. We try to make things very clear. And the tools, task delegation form, organization chart, these tools, this document helps have a good communication with the partners. Meeting was also, as you may know, during meeting we have communication, and we implemented meeting, monthly steering committee meetings, monthly international coordination meeting with the international study manager, with the regional manager, bi-monthly regional meeting with the regional coordinators with the site, and monitoring visit. And during this visit, we have opportunity to discuss with people on the field, to discuss with the team. The bilingualism, you know that ALERRT is a bilingual network. We have English people, we have French speaker, English speaker. So we make this choice to keep this bilingual character. And you can see all the communication were in both language. The email, report, you see the email here, we have the French version, English version, and here, all the SOAP, all the documents, we try to translate them. And I'm the biggest, okay, I think that I'm the biggest beneficiary of this bilingual character, because I can stand before you today and speak. If you saw me 2 years before, or 3 years before, it was catastrophic. Yes, I think I have a witness here. Emmanuel can say something about this, but I think today I'm more confident and I can speak. And this is thanks to ALERRT, I can say. Okay, others, WhatsApp. WhatsApp is, I think, a very powerful tool. I think I have the WhatsApp number of all, at least one person in all countries. Yes. So when we have some difficulties, you send an email, you don't have any answer, WhatsApp, and at the same time, I think I can have an answer. Email, meeting in person, very important. After meeting someone, I think things are different. Even if you send an email, it's not like before, because you know the guy, you have already contact with him, and I think it's changed things. So during monitoring visits, we meet people, and this is also something very important for communication. We faced, because yes, we put all these in place, but we faced some challenges. Demotivation, I talk about this. Attendees to the meeting that decreased, because as I said at the beginning, people are very motivated, but as the project evolves, we see this motivation get weaker. So we have to discuss to use all the tools of communication to help people come again. And even for the study we are implemented now, the nested study, we saw that people are not, because the project is long, 5 years. In 5 years, you can see that the motivation can decrease. But with WhatsApp, and with direct meeting, because when you send an email to all, for instance, people are waiting for the others to respond, but I have direct meeting with people. I send a WhatsApp message and we convene a meeting, we discuss, and this can help improve things. At this committee, this is a challenge because when you have a multi-site study, you want all sites to start at the same time. But due to problem with ethics committee, it's sometimes difficult. And we face this problem in one country, and we have to change because they have another ethics committee, regional ethics committee, but also valid. So thanks to someone in this country, we let the national ethics committee and we submit to the regional ethics committee. So sometimes when you face a wall, I think you have to walk around. All fights don't need to be. Yes, you don't have to fight everywhere, every day. COVID pandemic, this was a challenge, and we try to have this this procedure for remote monitoring. Because we recruited the first participant in December 2019, and comes the pandemic, and I asked my team what we have to do, because it's not possible to make the visit, the monitoring visit. And they said, yes, we have to wait. I said, no, we won't wait. We have to find a solution. So we drafted a procedure for remote monitoring, and we start remote monitoring until we have all the borders open. The decrease in the rate of recruitment, and we discussed with team to find the way to improve, the strategy to improve, and this through communication also. Okay, I'm at the end. I did it. Communication is not an option. Things will not always be like we want, but you have to be inventive. You have to be to innovate and develop strategy and communication tools to improve things and move forward. Thank you very much. You can see all the team we visit in each country and also all the partners. Thank you very much.
Thank you very much, Anani. Yes, it will only come from Anani. And this is the time for you to send the link, the Zoom link, to all your colleagues who might be online or want to join online, because we have a very interesting discussion forum coming up. And so I'm going to invite all of those who spoke, the panelists, to join me, Dr. Sylvie Kwedi, Dr. Antonia Foaje, and then Crystal, you may want to come down here. There might be questions for you, Dr. Meichui and Anani Baje. Questions have come in. You just have to. Dr. Sylvie Kwedi, what is your take on the development and presentation of policy briefs to administrative stakeholders at the end of the project? Oh, yeah, sure. Just make sure it's working. Okay, cool. And then I'll just list the questions and then you guys can go. Tony, can low and middle income country research institutions actually set up and or participate in setting up biorepositories? Anthony, you presented ALERRT as if though it's a consortium with no mistakes. What do you see, or what do you seem to have seen? I didn't get that right, but what do you think has been the greatest weakness of ALERRT as a consortium? Anani Baje, in applying the 5 C's in effective communication, i.e. confidence, communication, comprehension, complication, and complexities, you seem to have touched on the first 4 C's and deliberately left out the fifth C. Do you have solutions for all the complexities that you may have seen with ALERRT? Now, you mentioned demotivation, and I'll give you my take on the demotivation before you guys go ahead. And this is a saying from late Professor Ogogo Barandumbo. Comme on dit en français, paix à son âme. This guy is one of the most motivating scientists I've ever come across. He told me one thing that I have maintained throughout. When you are setting a consortium, you want the big names for sure, but make sure that from that very beginning, you have a backup junior scientist. Get them involved from day one. Don't let them come in when they're invited by their seniors. You insist to have them on day one, and that consortium will never, ever fail, because these guys are never demotivated. They are always on, kicking and ready for, it's working, yeah, kicking and ready. So get them involved in day one. I think somehow ALERRT was very successful with that, you know, blending the seniors and the juniors, and that's why if you look at the names for ALERRT, you will not see Anani, you will see somebody else. If you look at the names from, we'll go on, you will see somebody else who's sitting on the back now, but there's a big name in front. And right now, there is also a very big name that is supposed to come on. And I hope that we'll get a small name to fit that. Okay, that said, let's go with the first series of questions. Some of you did not have questions because I didn't get them. But as I get them, you will get your chance. Please. And then we'll take from after these first series. Go ahead, Dr. Sevikwedi.
Thank you, Dr. Palmer. I believe you asked the question about public policy to, policy briefs. Like I said, we cannot just do research for our own visibility as scientists. It has to be applied for the health of our communities, because we're health researchers. So once you have completed your research, you have analyzed your data, and we all know sometimes it works, sometimes it doesn't. How long have they been working on an AIDS vaccine?
30 years.
HIV vaccine, I mean, so sometimes it works, sometimes it doesn't. So whether it works or not, you are supposed to, and you need to write up policy briefs, and they are usually short, usually a page, quite short, on how your results, whether they were what you expected or not, can be applied to affect, because I'm not going to say change policy, because we all know that that process takes years and years, but at least your results can affect even just the mindset of decision makers. So it is important to prepare those briefs and present them to those that can be useful in applying your results.
Okay. Tony?
So the question, if I recall correctly, was about, can we actually set up biorepositories in LMICs? Yes. No. The more nuanced answer is, the easy thing to do is to walk in with a clipboard with a bunch of boxes and to go check, check, check. Oh, you didn't check this box. Sorry, you can't do it. But that's not helpful. It's not productive. What we need to do is we need to go in with a sense of curiosity to say, what do you have? What do you need? How do we figure out how to get you where you're wanting to go? And it doesn't have to be everybody can do every kind of processing or store every kind of sample from day one. Start out with something that is practical and move forward from there, and, you know, work with people, figure out resources, figure out protocols, figure out personnel, all of those things, and see it as a process. It isn't walking in and saying, you have everything you need, great. It's walking in and going, I see these gaps. Here's how these can be addressed. I will work with you on that. and to make it a process and just buy in. But that's how we're going to build capacity, is by actually coming in and building capacity.
Okay. Anthony and Crystal.
I just wanted to do a quick add-on to what Tony just said, if it's fine by you.
It is fine.
So sharing our experiences, for example, with our research institutions, there's an issue of competence, there's an issue of quality assurance systems, and there's an issue of what can you do with what you have. So our university, as part of the central lab that was built, set up a liquid nitrogen system using atmospheric nitrogen. And this has been very helpful to provide, small scale studies with liquid nitrogen to store their samples. And so the way, for example, to step in and do this would be to look at capacity, how much is being produced and how can we scale this up? Liquid nitrogen can provide cold storage, especially in resource limited settings with power fluctuations. Personally, our research institution has a backup and a backup for the backup and the backup for the backup for the backup. And we have technicians on retainer who have agreed to be called any time of the day. And we do have a caretaker who is resident on the facility, has their home on the facility. And so for a research institution like that, if you want to set up a biorepository, you just have to set up remote alarm systems to trigger the people who are responsible. You have to look at how is the cryomap being done? Where can we locate which sample at which point? Can we use barcode scanners to really do this? And these are really low-hanging fruit. You don't have to reinvent the wheel. You don't have to do much. There's a funding to expand our laboratories, and they dedicated the ground floor to as cold storage. Set up -80, -150 freezers. And we have local companies who can service these freezers. And so a service contract, in the long term, it helps you save money, documentation, quality assurance, using what you have and scaling up can allow people to start biorepository on a small scale and really scale it up once the systems are working. And once you do that, for example, Ghana representing the region, or Cameroon representing the region, or Uganda representing the region where people can actually send the samples there to be stored. Utilizing liquid nitrogen is easy to come with, easy to produce even when there are no electricity. And you realize that you really may not need millions to set up something very grand and with a system that operates in North America on the Europe. And this is really important to share with researchers so that they don't feel overwhelmed with how they will be able to keep their samples, to bear that in mind, that you start small and you ask for help to scale up and you have a good quality assurance system. So I think that's important to share as well.
Very well. Thank
now, to answer my question. So I'm going to do two things. As you're all aware, I am here to represent John, whose shoes are far bigger than mine. And they're asking me to share the weaknesses of ALERRT on this platform with the videos on. I think that the way John would have done this will be to throw the question back at the audience. Now, let's do this quickly. How many of you are part of ALERRT? Can you see by hand? You are not guests, you are part of ALERRT. You are part of the consortium, you've been involved. So the question really goes to all of us, and I think this is important. What I'll present is my opinion, my perspective. We want to know from you if 2-3 different people can just quickly, in less than 30 seconds, share with us what has been some of the challenges from your perspective, from where you sit, from your work with ALERRT. What has been the challenge for you? I think this is the best way to answer this question.
Remember that there are funders in the hall.
No, I'm aware there are foreigners in the hall. That's why I asked the ALERRT. So for those who are part of ALERRT, if there's anybody who has something on their mind or what the challenge may be, there are people who are well posed to perhaps maybe answer this question. I know Emmanuel is here and we've been driving her crazy. Maybe we should apologize to Emmanuel for the past and future hassle. Crystal has been doing a fine job at this. And so Emmanuel, maybe you want to step in? Yes.
is the language, bilingualism. And I think we definitely struggled at first. We pushed initially to try to do everything in English, even though I am a French speaker. And I think we really have made an effort, and I hope, one that's made a difference to try to communicate. But and a lesson really comes from FISA. We, the coordination, work package 7, took the lesson from work package 1, and then you showed the examples of the emails where everything's side by side. And we really tried to keep that going. When I stepped back from ALERRT, we found another bilingual, even more bilingual, someone to take it forward. So, I hope we've improved on that.
Okay. Christelle is right here. Just going to say that. That's exactly what she wanted to say. They communicate. Frank has something. And yes, note that online Frank and Bonnie are getting up to anything that comes in online. Go ahead.
Yeah, we have 11 attendees online. So if they post anything, we'll make sure we communicate.
Okay.
I think one of the challenges that we still struggle with is to completely measure and communicate the impact of ALERRT. I think a lot has been done. A lot is still staying in computers. A lot of engagements have been done that have not been clearly documented and communicated. And then the success stories of ALERRT haven't been packaged in a way other consortia can copy and use. So I think those are the most important from my side.
I think you're right. I remember the Madagascar story, and I think that was a very huge success in how Madagascar went around with the plague. And all of that thanks to ALERRT. And yet we are still to make the real impact of that story. So correct.
I'll add 2 bits to it. The first is that the consortia has evolved. What ALERRT was 5 years ago is not what ALERRT is now. And there are a lot of factors that contributed to this. But because we had something in our mind, something very specific, we tried to control the evolution of the consortium to fit what we had in our mind. But the consortium naturally evolved to what it is today to be able to meet the challenge that is today. We had a fair idea what we wanted to do, but we had no idea this was going to be the reality. And so when reality hit, there was the confusion about going with the flow, allowing evolution to occur and things to take shape, and also sticking to what we planned initially and making sure that, we're accountable. But eventually we tried a mix of both. And I'm sure Anani has a first-hand experience about coordinating the FISA study from the beginning and what the FISA study evolved in, and eventually it was a lot of frustration for him, aside the language barrier. I'm sure I have no idea how Anani handled this. I think it's one of the break points. The second thing I'll touch on briefly is mentorship. Is ALERRT giving opportunities for people to be mentored? Yes, but here's the catch, and I think it speaks to also demotivation. Here in Africa, you would have research scientists doing 7 to 10 times what their colleagues in Europe are doing. And the way it works is that then at a point you lack depth. You have breadth, but you lack depth. You'll be amazed about what we are juggling since we got to Cape Town, what I've been doing in the flight from Doha, things happening. Then at one point, I tried and I realized that, I have about 8 different studies that we're involved in and coordinate at different levels. What this means is that when you're collaborating with partners from elsewhere, you appear inefficient, you appear demotivated, but you are gasping for breath. One study is starting, another is ending. And so we barely go on break. Our European partners send us these auto messages. We are sorry on vacation.
Bank holiday.
Yes. So what happens is that they say that, according to the funding rules, you are committing 15% of your time and based on your salary structure. So we are having scientists who are being paid only 10% of their worth, who are being asked to give 170% of their effort on a study that they have been designated 10% they can't do anything about, who have to break their backs, sleeping 4 hours a day, doing this continuously. I mean, John is on his way, will be on his way from Canada and will arrive tomorrow. Prior to that, he was in Germany, and he's in the air 10 hours, sending emails around on different studies and different things. And it takes so much. At some point, you begin to shut down. And it is not that the people are not pulling their weight. It's just that they are behind on so much. But how do we find ourselves here? It's because we are doing much with little. And we are all we've got. We are the backup, actually. And so it is not that we are being overambitious. It is such that we commit much to the people who are able to deliver. And it almost always happens that the same people are being, and it's not because they are not interested in mentorship. However, the people being mentored are looking at using ALERRT, and for that matter, other consortia, as a stepping stone and a springboard to also elevate their career. And if they do well and build a skill, guess what? It's nice to have a decent salary. It's nice to have better resources and opportunity to do much and be more impactful. So they have to leave the system. And so we are training people who are one leg out, looking for their next opportunity to break big elsewhere. And we are having a brain drain in the consortium. We are overworked and not having enough time to really train people the way they're supposed to. We work them, and those who are good enough are able to learn on the job. But that continuity that is supposed to happen is not happening. And these are factors that are primarily outside the scope of ALERRT. But we just have to acknowledge them and know that they exist. And with time, figure out how to, in our own small way, and at the level of the consortia, be aware of this and know how to mitigate. And so perhaps this has been one of the challenges we've had.
Thank you very much.
Hopefully I don't lose my job.
Okay. I think Crystal's input was on bilingualism, that she says that had been dealt with. So the floor is open now. Yes. Mike, you can shout too. Or maybe I can take out this mic too. No, this one stays.
Thank you very much. I have two questions. One is to Dr. Nona.
Nona.
Yes.
Sylvie, yes.
So thank you about the point of taking back the results of your study to the community. I mean, I know some IRBs make sure you report the results back to them, but I didn't think about taking it back to the community. So thank you for that. My question is, so practically, let's say you are conducting a clinical study, you take samples from different people who visit your clinic from wherever. How do you take back the results to them? Because you probably don't even know where in the world they've ended up at. And also, what metric do you use to say, okay, I'm doing a good job at communicating back my results? Are you going to use the number of people who have heard about it? Because I know communication is not only just about disseminating the information, it's also about making sure that people receiving it understand. So what metrics do you use practically? My second question is to Dr. Anani. So for demotivation, how do you deal with that in long-term projects? Do you have any practical examples, especially in resource-limited settings, as Tony said, when researchers have all these things they are juggling and they are also human, they need money to take care of themselves and they need rest and all that. How do you deal with that practically?
Okay. One more question from your neighbor. Yes.
Yeah. Thank you very much. My name is Eric Okek. I work with Uganda Virus Research Institute, and I share the building with the implementers of ALERRT and EDCTP at UVRI. Though for me, my activity is mostly policy-based and program management, because I coordinate COVID-19 diagnostic activity in Uganda. So where ALERRT has been getting its information. Yeah, so I'm a stakeholder. You better treat me well.
Okay. All right. Question.
Yeah, question. I have two questions. One goes to Dr. Sylvie. I hope I pronounced it right. I am a scientist, but also happen to be a politician. Now, in politics, we are told there is a very delicate balance with what to communicate and what to keep. Okay. So my question is, actually, I have had issues. This is particular because my work involves communicating a lot to the public. Sometimes my boss say I over communicate. Sometimes he says I am under communicating. Then sometimes he says I'm putting out so much sensitive information, which to me I thought it's okay. So how do you strike that balance on what to communicate and whom you're communicating to, so that you can perform? You can guide me there. My second and last question goes to Anthony. Yep. So at the Makerere University, where I'm doing my PhD in immunology, we have a biobank and biorepository where we use the samples to do our research. But the biggest question has been, if I am using archive samples, let's say collected for a surveillance program by government or something, do I need to go back and obtain informed consent from the participants, the patients, or does like the Director General of Health Service give a blanket consent, or the president of the country can give a blanket consent for me to use the samples for my PhD study? Thank you.
Thank you very much. Last question from here for this round. It's unfortunate that they are all going to Sylvie. I thought that everybody would share the questions, please.
Thank you. So I have a few questions. The first two are for Tony. So I'd like to know, what kind of sampling methodology do you follow at the biorepository? Like, how are your samples obtained? My second question is, what mechanisms or strategies are in place to ensure that vulnerable populations are not exploited? And I have a question, a bit of a compound question for Sylvie. So you mentioned,
But I'm keeping track. Yeah.
yes, knowing your target audience. And my question is in terms of communication between researchers and participants at the recruitment phase, and as well as like throughout the other phases of the research. So as you mentioned, knowing your audience, I'm assuming you also mean following certain cultural sensitivities in certain communities. So as a researcher, sometimes you find yourself in a position where you have to follow certain sociocultural norms that you don't necessarily agree with or are harmful. For instance, gender inequalities. There are certain communities where the women have to take permission from their male partner to participate in a study. So as a researcher, do you think it is your role to challenge such gender inequalities or sociocultural norms? And how do you reconcile respecting the established sociocultural norms in a community and also challenging them and implementing social transformation through your research during your communication with the participants? So these are my questions. Thank you.
The questions actually took up all the time.
Okay. I'll try to be quick. Great questions. So I noted 4 questions. Okay, so now I'm going to try to remember. The first question was about going back to the community. How practically do you do that? And then what are the metrics that you use that to actually show that you're being efficient, or that your communication is working? So the way you recruit, the communication channels that you use to recruit your participants, you can go back to those same channels and invite the community, not the participants, because the participants are supposed to be anonymous. You invite the community to a dissemination meeting where you present your results. So basically you use the same channels, because that's how you communicated that here we are, we're doing such and such a study. And like I mentioned, you don't that is not your first entry, your first contact into the community, coming with your protocol.
as you're building your protocol and you're conceiving your study, it makes a lot of sense to go back to the community and engage the community in conceiving your study. How exactly would this happen? Those same channels that you use at the beginning, you use them at the end for your dissemination of the results. In terms of the metrics, I'm not going to say that there's a template there, you know, if X number of people attended or X number of people understood your message. I'm not aware of such a metric. Maybe somebody here knows. But for me, what is essential is always be open and for the community to know, and whoever is the stakeholder that you're trying to communicate to knows that the channels are open. At any time, you are open and available for exchanges. To me, if you are able to do that, if they are able to understand that, you've gone a long way. So those are the first two questions. About policy and striking the balance. That was your question. One thing is for sure, not everybody needs to know everything. One thing I learned, you don't share your budget only if it's extremely necessary. I know I spoke about transparency, but budgets are extremely sensitive and not everybody needs to know, because you open up a whole can of worms by sharing your budget. You may share big item lines, but if you go into detail, you're toast. So you really just need to know. You really had to understand your audience at the very, very beginning. Not everybody has to know everything all the time. You need to learn your audience and remember your communication plan is living and breathing. It can change, it can grow, it can be reduced, it's living and breathing. So it's up to you to learn your audience. Yes, I love your question. I love your question and I will go quick, I'm sorry. I'm in India conducting a study on tuberculosis, the incidence of tuberculosis in children from the day they were born to the 2 years old. I go into the community and I'm recruiting pregnant women because it's when the baby is born that I actually get consent from the mother. India, I'm a young, yes, woman from Cameroon, Central Africa. I'm not Indian. I don't know what happens over there. So when I get there, I had a big team. We're going from house to house, recruiting pregnant women. I'm noticing that we are informing the pregnant woman, but she won't talk unless her mother-in-law is in the room, not her husband. In Cameroon, I'm used to the husband intervening, but here is the mother-in-law. This is what I have to say. I have to respect that culture. Good clinical practice was written with a certain mindset. That doesn't work in every context. Yes, we have the instructions, we have the directives, we have the guidelines, but they were written by the people that understood whatever context they were writing for. They were not writing for every single context. So before you get into a community, first you need allies into the community to guide you. You don't go by yourself. You are guided and you learn about that community. Whatever you bring in, I am not coming as a, I don't know, developer of the, no, I'm coming as a researcher, but I need to respect the community. I think those were my questions.
Can I just speak some experience on this? So, yes, yes, and ensuring gender autonomy, what we have done in the past in these very difficult communities is to make sure that there's GCP compliance, whereas being culturally sensitive, like he said. So what we do is that sometimes you need permission from the chief, you need permission from the local representative, you need permission from the head of the home before you get to the participant. Now, this is how we achieve that. You give the consent forms to the head, the chief, you explain to them, you seek their permission. you seek the community leader permission, you seek the head of the home permission, then with their blessing, you ask them to seek the permission of the person of interest. Guess which one you put on file? The person who is being recruited, so that when your monitors and inspectors and regulators come, you have you maintain autonomy, but you don't disrespect the people. Your study is not the time to go and fix people's culture that has been in existence for centuries. And so you have to make sure that you don't disrespect the people. And the practical way we've done this is to do this. We keep the record somewhere else, but we keep only for the study participant on file. So that's one way to go about it. For the feedback, remember, different studies recruit different people by different means. Sometimes you recruit from the hospital, sometimes you recruit from the community, and the studies do different things. So for our seroprevalence studies on COVID, this is what we did. We created a form and we gave feedback directly to the participant. We gave a number of a medical doctor who will provide extra explanation in case they don't understand what is in the report. We use simple basic language to explain to them what does it mean when we find SARS-CoV-2 specific IgG antibodies in your blood. So we gave direct feedback to the people who contributed the data. We didn't share the high level data with them, but their personal feedback based on what we found. Then for the communities we engaged in, at the end of the day, if you went through the community, you hold another Durbar, meet everybody and share the level of information with them. In the hospitals, what we've done is that once the data is out and the paper is out, we will have seminars at the hospitals where the healthcare workers, the doctors who are involved, the nurses are giving feedback on what we were looking for and our findings. Is there a prevalence of a particular disease in the hospital based on the patients they're receiving? What can be done? What is our data telling us that is specific to them? We have recruited post-outbreak in a secondary school, and we give feedback, a report to the school authorities, not necessarily to the students, but to the school authorities who are in charge of the students. So depending on how your study was designed and the approaches, your feedback to the stakeholders may be different. For COVID-19, we created a dynamic dashboard, gave access to the government in our country to have real-time access to the data we were collecting to inform them. For our seroprevalence study, we gave weekly updates to the government via a template report we determined to help them guide on vaccination program and a bunch of other things, in addition to what was being given to the participants. So this communication may differ, and it helps to think through these things at the time of putting together your ideas and proposal so that they are very easy to implement in these.
5 minutes to the end of coffee. We need to choose here now. Are we doing coffee or are we taking the answers? One question.
I can do all three of them.
Okay,
quick.
please.
The ethics question, there was a perfect segue from the previous discussion. Ethics is both universal and local. So my answer would be talk to your local ethics chair and ask them a theoretical question. Say, I'm in this situation. How would you suggest I handle it? Right? That's the best way to approach it. And then they will tell you, do this, do that, or don't even ask me that question because I'm going to tell you no. In terms of collecting specimens and, how do we do that? We actually write a manual of procedures whenever we do a clinical study that outlines, here's how the collection is done. Here's the steps we go through. And so we outline all of that, and we're happy to share all of those documents. In terms of processing, we use standard operating procedures, and we're happy to share all of those. So that is a perfectly reasonable thing to do. In terms of vulnerable populations, that's study design. You decide which populations you're going to work on when you're designing the study. And if there are vulnerable populations, children, pregnant women, prisoners, whoever, you go in consciously with your how you're going to approach that, and you get approval ahead of time. And you think about the communication. You think about all of the issues related to it, because you want to make sure that you can address the study questions, but you also need to be ethical. And so, what is appropriate where I live may be different where you live. A payment that is appropriate for my location may be considered tiny in another country and coercive in another place. So it has to be informed by what's local.
Thank you very much. Please join me. There's a question.
The question about the motivation. Yes, I think the first thing is to know what is the reason first, because what you will put in place depends on this reason. Is it because they work too much but small money? Is it because they don't meet the initial objectives? Because when we are in the a network like that, you can see people. We have many people, but each have his own objective that you don't know. And if he doesn't meet what he was looking for, it could be demotivated. So you need to know if you can do something, you will. But if you don't, because if it's a question of money, for example, I'm not the one who hired this guy, so I cannot do many things. You see, but I will go to these people to know what is the problem. And sometimes there are people that want to do something specific, but they are boring, they don't know what to do. To this person, you can give something particular to do. It depends on the problem, and you have to address it case by case. Sorry?
Practical example of what you did to manage demotivation.
Practical, because in FISA, at the end, we have at least one person from all partners. We, even if some of them left, sorry?
You are calling us on phone.
Yes, yes. Yes, but I think it's you are there. You did not left. So yes, I think people are around. So if it's someone who left because for example, I have one of the partners who left and went to UK now. He left because he worked a lot, but for him, he was not. They did not pay attention to what he did. You see, I can do nothing at this level. You see, but so it depends. It depends. But I try to have contact, close contact with people to discuss and see what is the problem, and if I can do something, I do it.
Thank you very much. Please join me to thank our panelists. So thank you for joining us again on this session. This is going to be an interesting flip side of our first session on communication, because we're going to be handling negotiations, and how we've done it using examples in ALERRT is what we're going to be getting, but we've also had some invitations from other consortium and other initiatives. And one of those of our invited guests today is Dr. Yauba Seydou, who is currently the acting head of the Clinton Health Access Initiative in Cameroon. And so Dr. Yauba Seydou is going to be mapping out to us what you need to, how you map out your audience during communication. And so we would have another presentation from, again, examples from FISA, but this time around coming from Eastern Africa, and that will be done to us by Dr. Bernard Kikaere. We were supposed to get a presentation from Professor Boop, and that was just supposed to present to us the 3 steps to get what you want in a negotiation. And you can see my name was on the side, and maybe that's where we're going to share this orange in the proper way, using the Navajo experience. And I'm not sure if some people understand what I'm talking about right now, but we'll try to see. Unfortunately, I don't have any presentations for that. We would have a discussion forum, and that discussion will be led by Professor Trudy Lang here present. And then, of course, we'll come back for closing remarks. And so please, without much ado, join me to welcome Dr. Yauba Seydou, who is going to be presenting to us, mapping out the audience in negotiation. Dr. Yauba, please.
Thank you very much, Dr. Palmer. So I started off my research career as a Palmer student. I think at that point in time, we were conducting the in short efficacy trials, testing the efficacy and safety of artemisinin-based combination. And it has been a long time. I haven't seen him, and today I was kind of surprised to realize that he has put on some weight. He's gray, he's going gray and having glasses. But I think one thing that has not changed is his passion for what he's doing, and also his eloquence and what else, and his sense of humor. And then we did have a very interesting group, which is interesting in the sense that it was kind of similar to a group of or a herd of antelopes where the dominant male would chase out the younger ones. So those of you who are working at ALERRT, please pay attention, because you may at one point be chased out of the group. So it's actually a pleasure, Palmer, to have this opportunity to present this presentation. So as I said, I started off my career as a clinical researcher. Then I went to the industry, Novartis, and where I learned to design clinical trial protocols, investigators brochure, select sites for clinical trials, monitor clinical trials, train investigators, and so on and so forth. And then I went to MRC the Gambia, where I actually learned how to do the real job, implement clinical trials, generate the data within acceptable ethical standards and so on. And I was really pleased to see colleagues from MRC. And then from there, I went back to Cameroon to join the development sector, where my primary focus was to see really how do we get interventions to people who need them. What are the structures and systems that we need to have in place, and how do we make things work? How do we change research? How do we translate research findings into policies and so on? And believe me, I have learned a lot. In short, what I've learned in my development job is something that I think can be very useful for researchers. I've not learned that in Novartis. I've not learned that in medical school, and I've also not learned that in I've not learned that at MRC. And as Sylvie was saying, these are things that are not taught in typical PhD programs. So I structured this presentation. In short, I titled it Anticipating and Strategizing to Address the Inevitable Sociopolitics in Project Implementation. And I really want to seize this opportunity to promote the use of a tool that we are currently developing with the Bill and Melinda Gates Foundation. It's actually called the Communication Plan Template. So how do we move forward? Oh, okay, so I have this, at least this outline, which you can see. And in terms of background, I think we had this morning the different crises that that happened at the African Academy of Science, where a number of well-intentioned and designed projects were suspended. We also have had instances where well-designed and well-intended projects have been have failed to kick off. For instance, the Ebola vaccine trial in the Gambia, and then we also have instances where some trials have been suspended. Particularly, a good example is the tenofovir trial in Cameroon, or the infamous vaccine, the infamous Pfizer trial in Nigeria, that is actually kind of fueling some sort of anti-vaccine feelings, and also impacting the way research is being conducted in certain parts. And this sort of example kind of demonstrate the extremely punishing environments that many researchers face. And I think one person, was it Michelle? I think she beautifully summarized the different challenges that researchers faced. You can see them there. Imperfect research environment, uncertain logistic, unreliable infrastructure, untested technologies, official, initial, and outright corruptions. So because of this challenge, I think researchers will really need an arsenal to help them navigate the complex and punishing environments where they plan to conduct their research. And this is important for a number of reasons. Each research project presents unique sociopolitical challenges. It can be a clinical trial, it can be a genetic research, it can be, and so on and so forth. So each research has its own and it presents unique challenges. So what we know is that many research projects have a sociopolitical angle, and generally involve multiple stakeholders with diverse interests. And for researchers who are not like politically savvy, they can actually run into a situation where their research is compromised, delayed, destroyed, and therefore they need to have a socio-political strategy on how to navigate the environment before you even start implementing your trial. And really, what have I learned? I think in terms of implementing research, be it research or also a development project, having a strategy, in short, actually planning and developing a strategy will pay off. And there are actually 3 essential steps that one can use to develop a strategy. So the first one, which is really like my assignment for this presentation, is mapping the audience. Identify your stakeholders. After that, we have to categorize our stakeholders, develop a sociopolitical, and then develop a sociopolitical strategy. You can call it sociopolitical, you can call it whatever you want, but you need a strategy on how to handle the different stakeholders that you will identify in the course of implementing your project. So in terms of identifying stakeholders, I think the first thing that researchers would definitely need to do is to identify all the people, organizations, institutions, and departments that may impact their be impacted by their project. I think the list is generally very long, but if you spend time doing this, it's going to pay off. And once you have identified these stakeholders, you also need to kind of determine the benefit or the negative impact that each of these stakeholders is going to experience as a result of your project. And again, you also need to determine when this impact will occur. Will it occur in the short term, in the medium term, and in the long term? And then once you have done that, there is that need to brainstorm on the possible reactions. Right? Are you going to face opposition? Are you going to get buy-in, and so on and so forth? And then lastly, once you have done that, it's always kind of important to capture all of this in what they call the stakeholder table. And I think this is an extract from the, in short, an extract from the communication template that we are developing alongside information from other business books. So you have identified your stakeholders. The next step is to categorize them. So generally, I think Sylvie mentioned that allies is really good to identify who your allies will be. And these are actually people who benefit from your project and those who will be willing to commit support to your projects. And they may involve a diverse range of people, from funders, local or national governments, ethics committees, regulatory authorities, and so on and so forth. And also local dignitaries, tribal chief, local healers, and elders. And then importantly, you really need to identify the opponents. And these are people who will be adversely affected or inconvenienced by your project. And these are also the people who have the means or the resources to delay, to stop, to delay or stop your project. And they can be so many. So you can have ethicists, anti-research people, religious groups, social media influencers, anti-vaccines, and so on. And the list goes on. And then the next important category of stakeholders are the indifferent. So these are parties who are indifferent to your project success, but you definitely will need their support to successfully implement your project. And there are just so many of them. And this is really one of the areas where researchers actually neglect and can actually lead to a failed research project. So you have government officials that can provide you with all the authorizations you need, be it a license to import investigational products, or authorization to conduct your study, authorization to share data, and so on and so forth. You also need to identify, depending on the nature of the project, the people who will be involved in maybe giving authorization to transfer data or to transfer samples out of the country, and so on and so forth. Sample transportation is another important thing. So you need to identify those stakeholders that will be important and will be important in helping you transport their samples out of your research site and out of the country. And believe me, these things can really, really be challenging. Someone talked about liquid nitrogen. Another person talked about, clinical samples. So believe me, it's not everywhere that you can find liquid oxygen. I remember when we used to do clinical trials in the Gambia, to ship samples from the Gambia to the UK, we needed to import dry ice from Ghana. And the person who is the supplier of dry ice will see you as a small potato, because he will not understand why he will need to sell you 5 kilograms of dry ice, because there's just no commercial interest there. But this is something that you need to be able to enable you transport your samples within the required temperature, so you don't compromise on its quality. Another example is something like a bank. Yes, you got some funding from EDCTP, right? In short, you spent like months of sleepless nights to develop a proposal. You got like 25,000 US dollars for your first time. You're a young investigator and you are very excited. You provide bank details. The money is transferred, but doesn't hit your bank account. It hangs at the central bank. So your project is delayed. They start asking you to justify the source of the money and so on. So once the money gets to your bank, the same issue starts. Where did you get the money from? So you need to identify all of those things. Other important things are things like airline companies that will perhaps need to transport their sample. You are doing an Ebola vaccine trial. You want to ship samples to the US, and then you show up to the airlines. These are samples collected from Ebola patients and so on. The airline, believe me, it will be very difficult to get the airlines to transport their sample, right? And then the next thing is custom officials, right? You want to import investigational medicinal products that have not been registered in your country. How do you go about it? Yeah, you are a smart scientist or clinical researcher. You have all the connections and so on, and then you succeed to get DHL to import your investigational medicinal products. And once they arrive, they will ask you, where are the documentation? Where is the WHO pre-qualification? Where is the certificate of analysis and so on and so forth? And then your investigational products will get stuck and you will not move forward. So this actually identifying this these stakeholders who are indifferent, but who are actually like kind of who be critical for the successful implementation of your project is usually mission critical. And it is always kind of tempting for researchers, at least people who are new into the business, to go on and then establish long lists. But what is really advisable is to identify like the top 8, the top 8 whom you have like this reasonable conviction that if you don't handle, your project might be doomed. And that is also very important to really identify the opponents, because these are the people who prevent their project from kicking off. These are the same people who will actually lead to immediate suspension of your project, or who will even evict you from the country. Like the Tenovis trial in Cameroon, I think if at one point in time, even the ambassador of the US could not intervene. So once you have identified and categorized your audience, the next thing is really to develop your strategy. You can call it sociopolitical, you can call it whatever you want, but the important thing is that it should be a plan that outlines how you plan to deal with the reactions from the different stakeholders. So the first step is actually defining or establishing the type of response you need from the opponents. Definitely you want them to not to oppose your project. The indifference, you want to galvanize them to support you, and the allies, you also want them to commit support or to actually grant you support or access to their own allies, which you can use to influence maybe the opponents or the indifferent. So the next step, once you define the response, is to determine the major concerns bordering each stakeholder. So these stakeholders will always have concerns. They'll always have concerns. So you need to identify what is like their main concern, and then you strategize on how to handle that. The next step is to deploy strategic resources that you may have to influence the stakeholders, and then you should have an approach for deploying the resources to influence allies, neutralize opponents, and also energize or convince indifference. And the next step is to deploy the resources that you have to influence the stakeholders. So you can decide to reward allies as needed. For instance, one of the things that I see a number of organizations do is to actually help sites with infrastructure, like build a building to run clinical trials, or support with equipment and so on and so forth. So you're actually like helping the ally, which is the facility where you are going to conduct your trial. And then you can also like use your resources to persuade the opponents to actually cede their opposition, but most of the time it doesn't really work. It can work, but most of the time it doesn't really work. And then another important thing is really to figure out how to leverage your network connections to kind of influence the allies, the opponents, and also the indifferents. So at the back of your mind, once you are doing this, you must also have a plan B. And that is what they call safe haven. What are you going to do to continue implementing your project if all of this fail? And the safer approach is to have what we call a safe haven. And there are a number of instances where we have seen this work. For instance, Sylvie mentioned the fact that they did recruit patients from private health facilities. Believe me, if they started with public health facilities, they could have had so much opposition, right? And that will affect their impact, the impact of their project. I think Palma and myself, we also had the same experience. We went to a site to recruit malaria patients, spent about 3 months, got only about 8 patients, and we had to like relocate to a safe haven where we actually enrolled the patients over a period of about 6 months. But you didn't tell me the resources that that got wasted. And then another good example is maybe the field epidemiology program that is happening at in Yaoundé and not in Cameroon. I think at first the program used to happen at the University of Yaoundé one, but because of a lot of bureaucracy, infighting, opposition, and so on, they actually had to find a safe haven and they had to transfer the program to the University of Buea. So it's always important. Once during the course of establishing your strategy, you must always think about the safe haven, because this can be a geographic area or a geographic location that can enable you to carry a project over. It can be a subset of a population, or your safe haven can simply be postponing or delaying the start of your project, and then so that you can have enough time to navigate the complex sociopolitics. So that said, there are also some challenges because the business is not finished, because at times you are uncertain on where to classify each, on how to plan for each stakeholder. So in the event where you are uncertain about the type of reaction you can get, it's always kind of advisable to strategize, to plan to deal with opposition. In that way, if you face opposition, you definitely have the tools and the knowledge and the tactics to deal with that. The second thing is the speed at which with which you should get a response. Is it rapid or delayed? So most often it's better to prepare for a delayed response, right? Now, from opponents, it's better to prepare for a rapid response, because at times the response can be rapid and it can actually degenerate into a crisis. And if you don't have like a proper communication and crisis management or communication plan, then your project might be doomed. And the next type of uncertainty is the support from your allies and indifference. This is really one of the things we see. We sign contracts with donors, but we sign contracts with donors, and then it takes like maybe 5 months for them to disburse the money. So this are definitely going to affect the implementation of your plan. So most often it's kind of good to plan plan on how to deal with delays. So once you have all of this, the next thing is really to create what they call the tactic table for each stakeholder, starting with the most powerful opponents. And this tactic table will generally provide responses to all of these questions that you see on the table. And next, this is just like a case study on really how we navigated one complex problem in Cameroon. And in short, position one study that had a lot of, in short, a lot of opposition from very strong opponents. And the aim of the study was really to improve treatment outcomes in patients on chemotherapy by screening for drug quality using ChemoPad at point of care. So ChemoPad is a paper analytical device that is developed by Professor Maria and her team in the US. I think they have implemented similar studies in Ethiopia, Malawi, and so on. And it's kind of useful. You can use it at the bedside to actually tell whether the drug you're about to administer to a patient is substandard or falsified, right? So we had this problem. We had this problem in Cameroon. I think clinicians and even people who have had family members suffer from cancer had to go through pains. So clinicians will administer chemotherapy, but they will not see the clinical response that they are anticipating. So you give like a dose of I don't know which other medication, and then you expect to see something like alopecia, the hair falling off, or changes in the blood picture. But when you do like the clinical exams or biology, you don't see anything. Then you ask yourself the question, is there an issue with the quality of this drug? And generally, up till now, clinicians don't actually have a way of answering that question. And that is really like the main reason why we are implementing this study. Let us have a tool that could guide clinicians about the quality of drugs that they are administering to their patients. As you know, cancer is very deadly and it can actually plunge people into poverty and also depression and so on. So we had our opponents. The opponents were really distributors of substandard or falsified chemotherapy drugs. They could be distributors, pharmacies, medical delegates, and also a network of prescribers, because it doesn't happen in isolation. And then we had our ally, which was like one of the leading teaching hospitals that was actually expressed the concern. We have high mortality from cancer, irrespective of the fact that they are diagnosed on time, placed on treatment, and so on. So that was really like a concern to them, and they were actually interested in actually finding a solution to this problem. And then we had like the indifferent, that were the drug regulators. They have licensed this medication, but they don't have that capacity. They don't have HPLC. They don't have the other technology that is needed to test for the quality of a drug before authorization. So they were indifferent. They have licensed the product, but there is just no way they can actually tell whether that product is of poor quality, whether the products of poor quality, and so on. And then we, following that, we had to establish like our tactics. One, we needed to like block the opponents, avoid them, reduce their position, or secure support from an ally. In this case, that was like the general hospital. Then we needed to persuade our indifferent regulatory authority. So there is also one important thing that we need to know, or we need to remember, is the fact that for large and potentially controversial projects, it's always good to identify someone like a godfather or a godmother or a godparent or an organization that can actually shield your project and guide it through cultural, ethnic, religious, political, and also bureaucratic environment. So we really need that to identify that in the course of planning, we need to identify that heat shield. In case things go wrong politically, culturally, traditionally, who is that person or that organization that can actually shield our project? I think Sylvie mentioned that this morning about there's something in India and so on. So it's kind of good to identify those type of people during the course of project planning. Then we establish our tactic table, right? Providing responses to all the different questions that we set out. And this is actually how it looked. We defined the type of support we needed. We identified the major issue that was occupying each stakeholder and so on. So we also did that for our ally. I think the first one was really for our opponent. Then the second one, the second table for our ally, the Cancer Treatment Center, and the third was for the indifferent, the regulatory authorities. So for regulatory authorities, I think we had a number of things we had to do. We needed to offer training. We needed to connect them with the labs in the US or regulatory authorities in the US, and so on and so forth. And then we also kind of organized a number of meetings between them and other regulatory agencies so that they understand the depth of the problem, and the depth of the problem, so they can support this intervention. So this is really how we approach it. And to really summarize what I have been saying, everything actually kind of boils down to communication and negotiation. So you must have that identify the communication pieces of your project, and also have an approach, ensure the challenges and the approach on how to navigate these challenges. So the good news is that communication plans are things that are plans that are hardly developed for many clinical trials or clinical research projects. So I think this morning Sylvia highlighted the importance of that. But the problem now is that, do we have the tools? Do we have like a guidance document to develop communication plans? And that's really one of the reasons why Bill and Melinda Gates Foundation is investing on this. I think they have a team of people who are working to develop this plan. And the good thing about it is that it has guidance for all the phases of clinical trials. You can call it clinical research or clinical trials or whatever. So you have the pre, you have the during, and then you have the post. And importantly, the post, I think Sylvie mentioned, is actually like communicating trial results to participants. That is just one aspect, but there are also other things that will need to happen, like disseminating, educating, using the information for policy change, and so on and so forth. So the tool actually has like 3 key sections. The first section, it concerns pre-trial communication. It talks about the understanding the stakeholders through research, identifying the stakeholders, that is like mapping the priority stakeholders, developing communication objectives and key messages. So you actually see a table in the document that you can use and you can expand as you see fit. And then you also have another table that will enable you to like define the key objective that you want to attain, as well as the strategy that you want to adopt. And then you have a table that presents the implementation plan and so on. So there are a lot of tables. So I think it's a very important tool that the researchers can use to better plan for communicating, in short, to better plan the communication aspect of their trials. So to conclude, yeah, although I'm in the development world, I still share the feeling that clinical research, particularly clinical trials, will continue to play an important role, and it can actually help to save life, reduce the burden of diseases in Africa and other low and medium income countries. There is that need to strengthen the government and private sector to conduct high quality clinical research in accordance with internationally acceptable standards and principles. But there is also the need for an approach that should anticipate and address the inevitable sociopolitics before project implementation. And there is that need to have new tools and competent teams who are like qualified, politically savvy, that can leverage existing tools that are needed to innovate and execute high impactful clinical research. So again, you have like the key things that you definitely need to address when defining your socio-political strategy. And really, I just want to like end with this quote from Frank, which says, if you don't know for sure what will happen, but you know the odds, there's risks. If you don't know the odds, there's uncertainty. And the reality is that we researchers, we actually live in an uncertain world. So to end my presentation, I would like to acknowledge the Bill and Melinda Gates Foundation that paid my flight, Palma, who invited me and actually gave me this opportunity to present, and also to thank you for kicking me out of your group. Yeah, because I could have been somewhere else. And then I also want to thank the Clinton Health Access Initiative, Tia Norman, who is like our program officer at the Gates Foundation, Maria, who is like the developer of the cable part, and Ndasi Elvis, who is a colleague, Amani Adija, Amel, who is also here, Ksenia, and collaborate and so on. And then I also want to mention DAC A. DAC A is actually Design, Analyze, and Communicate, which is an arm of the Bill and Melinda Gates Foundation. And A here is actually Africa, because we want to like transfer what is being done at the Bill and Melinda Gates Foundation to Africa. So we got a grant from them. And the objective of the grant is really to collaborate with you researchers, the different consortia, to improve on informativeness of clinical trials. And I think we do have a little bit of funding to support things like trial planning, like developing a statistical analysis plan, developing a communication plan, community engagement plans. In short, those things that can add value and informativeness to a clinical trial. So thank you very much for your kind attention. And Palma will answer the difficult questions.
Thank you so much, Dr. Yahuba. Thank you so much. You see, you can never kick somebody like Yahuba off any team. Okay, So we will take our next presentation and skip the one from Professor Boop that has my name aligned and only come back to that if we have time. This time, then I'm going to invite the presentation by Dr. Bernard Kikair from East Africa to give us, some of those examples on negotiations that have happened both for FISA and for the nested study experiences from East Africa. Please welcome Dr. Kikair.
Okay, thank you. Sometimes it's difficult to talk when one, it's evening, but two eloquent guys have been talking. But I'll give it my best. Now, I don't know whether I'm going to give examples of negotiations, but I'll tell our story as far as the FISA study is concerned. Sometimes you do negotiations and you don't know you're negotiating. As I've been listening to your talking, I'm realizing, we've been doing many of these things without knowing, like tactics, the way you handle who, somehow you sit and you say, I think this one, we are going to deal with him like this. And the other one, there's a study we are doing and you get a lot of opposition from different places. And sometimes it's the policymakers. For some reason, policymakers choose to change policy when you're starting a study. And you planned it on a previous policy, It's one of those things that it's just interesting. Policies have been around for 10 years, and when you're starting your study and then the policy has changed. So you have to find ways of dealing with them. I think I'm very happy with that talk. So I'm going to talk about us in East Africa and what we've been doing. I hope this moves fine. So, okay, that's where I'm beginning from. So ALERRT, so we had partners in the East Africa, and that map kind of shows where the East African partners were for ALERRT. I'm looking for the pointer here. Is it that one? Okay. So we had ITM Belgium was working with Jimma University in Ethiopia. And then we existed as UNRO in Uganda. And then BNITM had partners in Tanzania. And then IP Madagascar was there. And then us at UNRO were the ones coordinating the region generally. And this is for the FISA studies strictly, not for all ALERRT activities. I think I needed to be very clear about this. And so as you can see there, UNRO, we had our site at UVRI, and then BMITM brought Korogwe from Tanzania. ITM was supposed to get us a site from Ethiopia. And, they were between cold feet, not sure whether they wanted to do the site or whether they were going to do the site. And then Madagascar gave us two sites. They gave us a site in Antananarivo, that is the Befelantanana, and Moramanga. So I think Anani expected 4 sites from us at the beginning, and we identified 4 sites. So there was never going to be any negotiations who should come in and who should go out. But what we were not very sure about was ITM, whether they wanted to have a site in Ethiopia. I think personally, I was really interested in having a site in Ethiopia. But ITM had other thoughts. I think they eventually went to Maferanya and they abandoned us, which was a bit painful. But then they took, because Madagascar eventually could not start recruitment in Moramanga, partly because of COVID. And so that the funds that would have gone there went to Maferanya for BNITM. Okay, so we were the regional coordinators, and I was really the one in charge, I think, and Anania did not forsake you. Yeah, Anania suffered because most of the study coordinators he has worked with in Cote d'Ivoire have got bigger jobs and they've been leaving. So he recruits one. I think we started with Robert. He went, then we got somebody else who went, and now we have another person. I hope it doesn't go. So I was working, and then we got a very, very good clinical research associate, Cynthia, who worked with us for 2 years, and she left. So we struggled to get a replacement. We finally got a replacement, I think about a year ago. And so, but even now, we had to call back Cynthia because Cynthia did a very good job. And for all the closeout monitoring visits for this, Cynthia, even right now, Cynthia is in Madagascar closing out Befel and Tanana, working with Menan. And the reason we have called Menan is because Cynthia doesn't know French, but Madagascar is French speaking. So Menan speaks the French and Cynthia does the writing. He speaks, translates, and I was talking to them yesterday. They are doing a good job. So these bilingual things are very serious. I think when we went to do the training in Madagascar, we had to call a nanny because yes, we could talk the science, but we didn't know French. So we ended up almost going for a tour in Madagascar because Anani did all the talking and we did all the sitting. Because they were talking French and you know, with all due respect, I know nothing in French. I think after bonjour, I don't know anything else. So it was a very interesting thing, but we've done that. So, and then at the sites, like Anani has said, there was the PIs at the site, okay? And then what he called the supervisors. So each of these sites, but I think I didn't put it here, but for Korogwe, I think I've gone through this, so I don't have to talk about that. For Korogwe, we struggled to find a site supervisor. We had BNITM, and Mikey was very, very helpful in setting up Korogwe in Tanzania. But unfortunately, the site PI became a problem. I think up to now, even when we were closing out, we were not sure who to deal with because the key personnel that was supposed to deal with was on a very long-term sick leave. But somehow is the person that had to give us, you know, those things he has been talking about. The gatekeepers, is the one who had to give us leeway into Tanzania. And so they gave us a gentleman called Omar. And so we worked with Omar, but Omar got a PhD and left. So things became a bit interesting, but I think eventually we've been able to. So like I said, we eventually had 3 sites. That is how we worked. I think I don't have to talk a lot about this. I've already said the sites we worked with, Korogwe, Befelantanana in Madagascar. Muramanga fell out because they failed to recruit anyway. And that's how we operated. And in the above circle here, this is where Anani and the team from Abidjan were operating. And then for us, we operated here. I must say that we doubled because we also had a site on our own. And then, and these are the sites that we worked with. So there has always been this constant cycle. I must say it's not easy. You know, you talk with Anani and then you're kind of sure what you want to do. But when you come to the sites, you know, these guys are not there in these meetings, okay? They are not there, so they don't know what you agreed. Maybe you talk to Maike for Korogwe because she's the person you have a working relationship with. But Maike is in Germany, okay? And you need this information down at Korogwe. And that made things a bit complicated. And what made things a bit more difficult was, you know, the funds and the budget. You know, it came from Emanuele, you know, she should send the money, but, you know, this money would go to the partners. They would not go straight to the sites, okay? And so, you know, you need some things done in NIMRI, but the money is with BNITM, and maybe they are still working out MOUs between BNITM and Korogwe on actually how to use these funds. And so those issues actually caused a bit of delays, a bit of complications, and they are a reality because we keep seeing them in many, many collaborative studies where the implementing site is not a budget holder And you know, sometimes the budget holder has completely different ideas, but somehow you pull through. So we did site visits to each of the sites. We went there and we did two activities in one. We went to initiate the site, but we also went to do the protocol training and to meet the teams at the sites. And these site visits were about 2-3 days, quite short. So they were very packed because you're doing so many things to finish. Thank God for Zoom. Thank God for email. I think that time there was no Zoom. We're doing more of I forget what it was. Skype. Yeah, we used to do Skype. So we used to do Skype, very unreliable sometimes. Korogwe, particularly, Korogwe connection is not the best in Korogwe. You have to stand in certain corners to be able to get the network. So it was interesting. But anyway, we managed to go and do that. And then we did that. Like I said, Anani supported us a lot when we had to go to Madagascar. And then after the initial visit, I think Madagascar we did November 2019. And was supposed to start enrolling. And then we're supposed to do subsequent visits. And then COVID happened. So the whole world went into hibernation, safe mode. Everybody was closing themselves up in their room. So what we had to do was, like Anani said, we resorted to virtual means. So, remote monitoring, which was quite interesting. You ask guys, please scan and send through. And you are assuming they have a scanner, first of all, and they can, transmit that by email. Email has a limit of, I think, 20 MBs. Beyond that, you cannot transmit. So how much of that information is going to come through, and and all the related challenges. But I think by and large, Cynthia handled this quite well, linking up with the team of Anani and the sites and making sure that things go on quite well. Korogwe was a very interesting. It's a very short flight from Entebbe to Arusha, probably 45 minutes. But then you have to take a road drive of 8 hours. Yeah, so you imagine you drive 8 hours in country, but 45 minutes across borders. So I think we arrived in Arusha about 7 p.m. And then we had to drive for 8 hours in the night to Arusha, to Korogwe. And that picture is, by the roadside. It's really buried in the mountains with clouds all over the place, but it's beautiful along the road. Very tempting to take pictures until your phone memory is finished. Now, when we went, it was actually a very, very rainy season, that even the clinic facility got flooded. So sometimes, I think I wanted to show the next, that particular picture there. I was doing the protocol training there, and the rains came. So we had to shift, kind of move to another position because where people were seated was quite flooded. That's when we took the picture with the team, and those are the files of the study. Moramanga, Befelantanana, we went in November. We met with the team and we did everything. Anani really helped us, the language barrier issue. But when we went, there was a cholera outbreak at that time. And so my team was very scared. They thought they were going to get cholera. And the hotel we were booked in had, the water was this color from the tap. And so people were scared. I don't know where Anani was staying, whether it was much better than us. So things were a bit interesting, but we managed to pull through. And I think that's what you experience when you go to the field. But like I always tell people, when you go to do work, please try to see what are the beautiful things in a country. It's not always sad news. So we managed to see these beautiful monkeys, and that's the team that we went with. Thank you.
Thank you so much, Dr. Kikare. And you can see that it's been a really rich experience. And Professor Boop wasn't here, so
we would, I know some people have already heard this story now, but a great majority of you did not hear the story. And this is going to take us through our 3 steps in negotiation. And the first, of course, is that, you know, to sum it up, you'll open up the negotiation, and then, of course, you're going to hammer on to what you want, and then you're going to close the negotiation. Easy said than done. Practically, back to the orange story. And for those of you who are not here, I had this orange that was given to me. I traveled a long way with this orange. To divide it between my 2 daughters, 7 years old. Oh, thank you. Sorry. 7 years old, Were, and 10 years old, Beringo. Beringo wants to make a cake. Were wants to eat the orange. And the question was, what do I do if I meet the 2 of them fighting? We got some insights already in the morning, and to keep a long story short, because we don't have so much time, somebody said that we will have to ask some questions. And I think one thing I've learned from Dr. Yauba's presentation is to ask the right questions. So I guess the right question to ask will be, why do you need an orange? And not just pretend that I am the dad, I know it all, I'm going to come and divide the orange into 2. Because in doing that, as we saw in the morning, you could be surprised that you see half of the orange in the bin. Of course, half of the skin and half of the pulp. And if you come back and ask, why did you throw your orange? And you're surprised. And my 10-year-old tells me, Daddy, I just needed the skin to do my cake. What do? Feel stupid, okay? And then my young one, of course, Daddy, what did I need the skin for? I threw it away. Again, feel really useless. I should have just asked the right question, right? At the beginning. Why do you need an orange? Or what do you want to do with the orange? And Beringo, 10 years old, would have told me a very nice story. Daddy, you know what? We learned how to make a cake with the skin of the orange. I need the skin of this orange to make my cake. And Wera, of course, she likes food. I want to eat this orange. And I would have had 1 orange, peeled it myself, take all of the skin and giving it to Beringo, 10 years old, go make your cake. And then take the whole pulp of the orange, give it to Wera, eat your orange. All of them would have left very, very satisfied. 1 orange, same resource, double satisfaction for all of the stakeholders. The moral of that story is that don't think you know it all, even when you are very knowledgeable about the situation, because the current stake might be very different given that situation. Dr. Yauba Seidu, I'll invite you here to the podium. And then I'll invite Dr. Bernard Kikai. I will also find a place and sit down after I've asked them some very challenging questions. And then open up the discussion for the audience. And then Professor Trudy Lang sitting here will do the wrap up. So please feel free to ask your question. For the questions that will come online, Frank and Bonnie would let me know. So the first question is to Dr. Yauba Seidu. So in mapping your audience, it can be complicated when you have to deal with moving targets. By moving targets here, they mean that after you finish negotiating with one group and then a new group of stakeholder comes in. And the question is, what has been your experience in having to renegotiate what you had already negotiated with these teams? And to Bernard, your question is very simple, that in all of these challenges, did you succeed in doing what you had to do? 2 questions and the rest will come from the audience.
Pam, I think the approach I usually adopt is very simple. I answer the simple questions and I leave the difficult ones to my teachers like you. So let me try to answer the simple one, and then you take on the difficult one. So the moving audience? Yeah, I think that is very common, because even their stakeholders, their perspective might change, right? you may not only have new stakeholders emerge, but the perspective of the actual or the initial stakeholders may change. So that's why in one of the tables we talked about, we discussed about anticipating the reactions in the short term, the reactions in the medium term, and the reactions in the long term. And then the table will also need to be living. So you always have to like update it from time to time. Right. And the interesting thing about the tactic table is that when you do it, you tend to see that many stakeholders may be impacted in either the directions. It may be impacted negatively, at the same time, they may be impacted positively. Right. But the common trend is that most of the stakeholders who are impacted negatively, the impact, or the stakeholders who will actually be impacted positively, the initial impact is usually negative. So it can be related to like increased workload, increase inconvenience, and so on and so forth. But if you manage to navigate that spread, that aspect, then in the medium term, their impact will become, at least will move from negative to positive. So the second question is the stakeholders that may emerge during the course of your project. And this is really typical, particularly for projects that take a long time, and for projects that kind of generate some sort of controversies. These are projects that will actually result into maybe politicians stepping in, like the xenophobia study. So it started, nobody knew about it, but when things went wrong, everyone knew about it, including the president, the minister of health, and so on and so forth. So it's always kind of good to establish timelines at it, maybe on a quarterly basis, to like sit down and look at their stakeholder table and do some sort of M&E to look at what is going well, what is not going well, and at the same time, and the progress you are making, and scout for new stakeholders that are emerging in the space. So Palmer, that is like the easy part of the question. So answer the.
Bernard has actually examples for the difficult part.
Okay, so this thing of negotiating, renegotiating, you finish this, it pops up in another way. It's things that we see every day as we do research. So the thing that is fresh on my mind is we are doing a study, point of care viral load monitoring for children. So when we designed the study, the whole of East Africa viral load cutoff to start intensive adherence counseling was, I think, 1,000 copies per mil. That's the WHO standard. And so we say, okay, we're going to use a platform that has a sensitivity of up to about 500 copies per mil, but would still be within, range. Then as we move, Tanzania shifts and says, no, we're starting intensive adherence counseling at 50 copies per mil. So that means that our platform is not relevant. A month down the road, Kenya moves and says we are going to 200. And Rwanda says we are going to 200. And Uganda is in between. They want to go, but they don't want to go. And so the first point is, so my platform can't work. At least for 3 partners, the platform can't work. We need to think again. So there is a point of care platform that can actually detect up to 20. So the first option is all of us should switch to 20. So we sit as a study team and we agree we should switch to the other platform. Challenge is you've not budgeted to buy these platforms, okay? The other platform was offered by the manufacturer. These ones you have to buy. So the first attempt, I says, let me talk to the manufacturers of the second platform. So I ask around until I identified the key people. I think one was from France and 3 gentlemen were from Kenya. So we organize a Zoom meeting and I make my presentation. And the first statement I get from the other side is, you're adding nothing new. We have no business to work with you. It's blank. So it means that where you're thinking you're going to get help from, they've actually shut the door. And they're like, no, this is old information. It was done by Clinton Foundation and everything. And I'm thinking, how did I miss that? Like, you know, when you're writing proposals, you scratch around for everything that is written and done. And there was nothing. So I'm thinking, did I miss that? Then the gentleman says, but you see, anyway, we generally don't do placements. But even if we were to do placements for your study, we can only do it in Kenya because we can only do it where we exist. We don't exist in the other countries. So we separate, and I was planning to do a rebuttal. So I do a rebuttal on email and they never got back to me. So we are stuck. Then we decide Uganda, we shall continue with the old platform since it's still at the border. By the time they make the decision to switch, we shall have, you know, put in quite a number of people. And, you know, I'm friends with the coordinator for children care and treatment at the Ministry of Health. We're classmates at the medical school. And so, and she's around, she's not in this meeting. So yesterday I was asking her, so when are you guys switching to 200? And she said, January. You know, the government is going to declare January as the time to change. And luckily enough, most of our sites, I think we need about 34 children from each site. And most of our sites we've done, I think one has done 23, the other one has done 20. So we've kind of moved a bit faster. Now for the other countries, we changed strategy. Because most of these platforms anyway existed in the country. They were using them for COVID, for many other things, and now they are being redundant. So we agreed with the country investigators to begin to talk with the government, because government own these platforms. So begin to negotiate with governments to allow you now do HIV viral load with those platforms. And we've literally been successful in all the countries. We don't have to buy. We didn't go to the manufacturer to give us placements, but the governments have been happy to provide the platforms for us. And I think in one country, they've even offered the cartridges. I think in the others, we'll probably have to procure the cartridges. And for me, when he was talking and when he asked the question, I thought this is something that, you know, it happens on a day-to-day basis. You face it every day. And we are hoping we'll be able to get the participants in those countries because, you know, there are other ethical issues that come up and, you know, but at least we've moved. With Uganda, I'm sure by January we shall have closed recruitment. That there's no question over that. I'm going back to make sure we ramp up this recruitment to make sure by the time government is saying, oh, we've moved, I can comfortably flag my hand and say, yeah, been successful. My question, in all we did, were we successful? I think we were. We were because Uganda were able to recruit the 625. I think Korogo was able to recruit the 625 and follow all of them through. I don't have the statistics. I don't know how many failed and like, you know, fallouts and lost to follow up. And Madagascar, I think we did about 480, especially knowing that they started recruiting in the COVID lockdowns. I think we were successful. Thank you.
Thank you very much. Yes. Anani.
As we are talking about negotiation, Bernard, can you talk about the negotiation we had on the budget, the monitoring visit budget? You remember?
Okay, I'll take that one and take one more. Yeah, just take your question. One and then one. Oh, same to you. You sent me okay from online.
Okay, thank you. I just want to comment on the story that Palma used to explain negotiation. One of the key things that was clear in the story was that both of your daughters knew exactly what they want. And when you're going to a negotiation table, it's always very important to know what you want, because you succeeded to satisfy both of them. But one other thing that we fail to understand at times, especially researchers, especially when you're looking for a grant, is that at times a no deal is a deal. In the sense that you actually know what you want, you went to the table, you couldn't agree, at the same time you don't want to compromise. Because there are situations where the only deal that you succeed to get would lead to, I don't know, maybe findings or maybe carrying out things that will not be useful, but you actually went into the deal. So the comment I want to make here is that whenever you want to negotiate, be sure about what you want. Be sure about how much you can go to compromise, because at times, if you go to the table without knowing what you want, you will come up with what you don't need. And that has to be very, very clear in every negotiation. And once you choose your position, it should be firm, but it doesn't mean it's cast on stone. But we should be able to be very careful about how flexible we are, which may compromise the value, the quality, and the integrity. And that's very important. Thank you.
Thank you so much. One last question, and you only have 5 minutes.
Thank you. Mine is a very simple question on mapping stakeholders. You talked about identifying a godfather. So the question is, how do you ethically identify the godfather and they remain independent? Thank you.
Good question.
And last one.
Okay, thank you. The question is to Dr. Yauba. When you talked about the tactic plan, I was curious about the role the media would play in our how there would be part of our stakeholders, because the project we did last year, the media was actually one of the key reasons why we had the commissioners buy-in. We used it to get her buy-in. So I wanted to know how we can use the media in our negotiations and to turn oppositions into allies. Thank you.
Okay, last one.
Yeah, maybe more of a comment than a question, but also first to say thank you very much for really good discussions. And maybe just to comment on identifying a godfather or whatever the term you used, and also informal engagement. I have a colleague who is very good with engaging with government and all that. And what he always says is more deals are agreed to over a cup of coffee or a beer bottle than they are in the sort of formal boardrooms. And this is something I think a lot of scientists don't understand, but people in the private sector, people in a lot of these advocacy groups and those sort of things, they are very good in identifying how they'll get to the minister. Trust me, you go to a minister in a formal setup, they have 10 minutes, you enter the boardroom, they say present, they're like, thank you very much, we will see you. What you need to find is the assistant and find out and make friendship with them, and then find a way of getting to sit with the minister, not when they're in the formal setting, in a less formal setting, in that golf club or wherever, then you'll get your things done. So it's also very important that we learn to go beyond the formal structured to sort of the more informal. Unfortunately, many of our organizations, and understandably because of issues of integrity and accounting for money and all that, do not consider that. In fact, you look like you're breaking certain conflicts of interest and all that, but that's really where deals happen. Over.
No, thank you very much. I totally agree with you. So I think in that scenario, at least what the management literature suggests is really to map out their allies and then map out their allies' allies. All right. For instance, you have the minister, and then he says the personal secretary. Maybe your first target will be like the personal secretary, like one of your key allies, and then maybe you want to leverage on that ally to get access to the other ally, right? So it goes either way, right? So that's that is very helpful. And then you are also absolutely right that many decisions are not taken in the boardroom. A good example is really like grant applications. Someone told me, I don't know whether that is true, that by the time you see an RFP out there, know that in short, 90% of the times, the grantee is already known. Yeah, so I think having that experience with Gavi and BMGF, I really tend to believe that negotiation actually really needs to start somewhere far behind, engaging their audience, communicating with them, establishing that rapport, building that confidence, and so on before the time reaches. So in terms of the Godfather, I think there are a number of important considerations. I'll give you an example. It's something we see not really in research, but in development or maybe rollout of public health interventions. If you take something like HPV vaccine, right? You take something like HPV vaccine, is it HPV vaccine? And even the tetanus toxoid. So you have like a set of Christian doctors in Kenya who have been really waging a war against this intervention since the 80s, right? And this has actually spread across Africa. So which actually means that if you really want to like get young girls vaccinated against HPV, in short, one parameter of success is that you must figure out a way of really handling the Christian community, particularly the Roman Catholic Church, because they have such a very vast influence on the population, not only on their faithful, but most often across the country. So I think for us, what we did when we were introducing HPV, we got a lot of resistance. But one of the good things is that we actually had a colleague who was like a friend to one reverend father, and that reverend father was like it was actually a bishop. He was actually like the president of the Episcopal Conference. So we had to like meet with him, with the technical staff, all the professors and so on. And believe me, someone said if you have too much knowledge, you can actually spoil the negotiation. And we actually saw that. Yeah, because the professors actually spoiled they actually spoiled the first negotiations. Right, they were so arrogant, so rude, and condemning the priest. And that is really not what you do in a negotiation. You really need to, like Palmer said, a win-win situation. You need to understand the context. You need to understand the interests of everyone and so on and so forth before taking your own position. So the first round was a complete failure to the point where that ally did not even want to see us. So we had to like go back again and then take like people, particularly the media, explain to them, because at this media people who are pro-health, who have been trained on health communication, who actually understand and who can actually like kind of translate scientific jargons into a layman's language. So we had to leverage their support to go and meet again with these Catholic authorities. So they presented the thing in a way that we as technicians, we could not present, and these guys understood. And the next step was really to organize another conference, another round table again with the different priests. We did. We had another meeting again with them. And finally, they had to like issue a communique recommending their faithfuls to take the vaccine. But the damage has already been done because many Christians, in short, social media. So social media has already had its own impact on the target. So there was that need now to go back and then start thinking about how to really counteract the message that has circulated via social media. And that is where you really need like people who are very talented in blogging or people who are very talented in social media to see how they can design messages to counteract the messages that have been circulating. So it's some sort of a very complex situation. But the unfortunate thing is that we don't invest a lot in that area, particularly looking at the influence on media, on research projects or public health projects in general. And I think I remember I think last year, in short, when in the middle of this COVID vaccine deployment, there was a lot of hesitancy across the continent. And that is when an organization like UNICEF actually even realized the need of really having like a department that should be in charge of social media. So they employ people and then train people and they tax them with creating messages that they can use on social media to influence the continent. And I think there are a number of reports on that. But what I don't know is how effective that strategy has been, because I've not seen any report. Okay, thank you.
Yeah, maybe half a minute. Okay. half a minute, because I don't, Sylvie said don't discuss budget things in the open. Yeah, but anyway, it depends on who. But I think the short and long of it is that because of the way the FISA study was set up, institutions had budgets, coordinating institutions had budgets for monitoring. But at some point, it was obvious because of the changes and the challenges we're facing that we had to give back some money, not back, we had to allocate some money given to us to the Ivory Coast team to be able to successfully do things. And of course, it's not always a straightforward thing. Once they've given you money to give it back. But I think we managed to negotiate through that. Even right now, I think Menan is in Madagascar, but we had to say that use the money and then we shall refund the money. So these negotiations go on, and I think they make things become successful eventually. I hope that is fair enough to everybody, to just know that it is still possible for a partner to get a budget, and there is need to cede that budget to another partner, and those flexibilities actually happen, but they'll make the work at the end of the day successful. Thank you.
Now, it's 2 minutes now. He's aware that he had to. Okay, so thank you so much to all our panelists, Dr. Yauba, Dr. Bernard Kikaer, and I'm going to invite Professor Trudy Lang now for the wrap-up.
Thank you, Palmer. Gosh, what a marathon day and afternoon it's been, but how nice. Palmer and I are twins, you can see, can't you? Look. Because I know, it's a surprise. Because we co-lead the capacity building work package, which has been a pleasure for so many years. And just look, congratulations, everyone. What an achievement. Everybody, I mean, it is what a lovely, and what there was a lot of effort to make sure the symposia happened around this conference, and thanks everyone, who you are, put in all that effort to make this happen. So well done, and a great topic to cover. So just a couple of remarks, and sort of hopefully I'm going to try and carry this through into what we're going to do the next couple of days, and then beyond with ALERRT too, because it's really important. So ALERRT came along, we were in the sort of post-Ebola craziness, but the reason ALERRT works so well is that so many people already knew each other and collaborated, and we've been talking about the EDCTP networks of excellence. Lots of the same gang came together, and then some new partners, and it's all about transferring know-how. It's the same deal, right? And I think it was really great hearing about Madagascar a few times, and one of the earliest things we did with ALERRT was there was a plague outbreak, and we went to have a look, and we developed this idea around doing a rapid assessment for clinical trials. So we went to see what the clinical trial capacity was, but guess what we ended up talking about? Surveillance. And because there's no surveillance system in Madagascar, and they'd thought about it and they wanted to do it, and they just had no ability to quantify, do that. It's all about a research cycle. We'll talk about this a lot over the next couple of days. And so what do we do? On the hoof, we connected up the team in Kilifi who've got the long-standing DSSS, and then we connected them up with the Madagascans, and we did this exchange visit. So it was that responsiveness and looking at what the gaps were and filling it. And I think that's the story of ALERRT, people just seeing where the gaps are, working together, sharing knowledge. So this doesn't stop here, of course. How do we capture what's been discussed today? But also we're at that phase, the ALERRT now looking forward to, there's a no cost extension and looking at what's next, but we must capture what we've done. And we've talked about this a lot, haven't we? Not just the capacity building work package, although that's obviously the most important one. But there's been so many good outputs, and, with so many of us have become friends and worked together over this, the work that everybody's done with the data sharing pieces, with the protocols, with the, there's just so many resources. We're sharing them and we're capturing them, but we need to write it up. So there's lots of opportunities for doing it, but I just want to call out the opportunity we have with PLOS Global Public Health, that they're running a special edition for the conference, but it means we can put any number of papers forward under that PLOS Global Public Health umbrella. And so if it's all around capturing outputs, how things work together, the network of the networks, I think there's obviously any number of papers that can come from ALERRT, but this is such an opportunity, especially the capacity building outputs. And well, we've talked about this as well for lots of the different elements. So please make the most of that. I also wanted to call out, it was just such a nice opportunity to link this up with the biorepositories discussion. And I think Matthew is, I don't think we've seen is, but the, again, for taking these things forward, you know, it's such a gap, it's so important. And that's a really nice opportunity for a really strong partnership and hopefully getting funding for that and developing some tools on that.